Good morning, sir. You all are live now.
Okay.
Good morning, sir.
Good morning.
Hello, sir, everybody. Morning, Venant.
Morning, sir. Morning. Morning, sir.
I think so. We are done here.
Dr. Sandeep Mahajan भी आ रहे हैं? हाँ जी सर. हाँ. Hi, Dr. Sandeep.
हाँ जी, morning, sir.
Good morning. क्या हाल है?
That's fine, sir.
अच्छा बात सुनो, डॉक्टर संजय वेदावन एडमिटेड है?
हाँ जी, sir. They will be quite sick, sir. परसों वेंटिलेटर पे गए हैं.
ओहो, मुझे तो अभी पता लगा यार, तुम्हारी और ये तो पता ही नहीं था कभी. कितने दिनों से दाखिल था?
अच्छा 10 दिन हो गए.
यही कोविड ही?
कोविड से. एक बार ब्लूटूथ स्पीकर लगा के देखता हूँ अगर ये लगते हैं तो.
यार लाइव सर राइट नो. कोई नहीं, अपने ही बनते हैं यार. Dr. Ashwini sir, good morning. Dr. Raj Purohit sir, good morning.
Boss, good morning.
Morning sir. Morning.
Good morning, Anil ji.
Hi, good morning.
So I'm there, ready.
हाँ बिल्कुल बिल्कुल.
Thank you.
अच्छा ये बताओ, एक तो चेक पॉइंट इनहिबिटर्स आप बोलते हो, एक को क्या
गुड मॉर्निंग श्याम.
हाँ, good
हाँ
morning.
भाई अश्विनी क्या हाल है? हेलो.
और वेदांत ठीक है, आवाज आ रही है?
हाँ जी सर, परफेक्ट. हाँ अश्विनी.
हाँ जी सर, गुड
morning.
मॉर्निंग. गुड मॉर्निंग सर.
हाँ भाई श्याम.
हाँ हाँ.
देखो चेक पॉइंट इनहिबिटर हो गया, एक दूसरे चीज क्या टर्म यूज करते थे, कुछ टीकेआई क्या?
हाँ वो ये
हाँ टीकेआई
है
जो सुनिटिनिब की बात हो रही थी ना कल.
हाँ.
जो पहले यूज करते थे.
हाँ.
और ये पेजोपिनिब, ये टीकेआईज हैं, ये टायरोसिन काइनेज इनहिबिटर्स हैं.
अच्छा अच्छा, उनको टीकेआई.
हाँ.
तो डॉक्टर सज्जन
वो
चेक
चेक इनहिबिटर्स में नहीं आते वो।
सज्जन जी जरा प्रकाश डालिए।
अरे सर आपके सामने प्रकाश तो आपके ऊपर ही है सर सारा।
हम जरा सन में बैठे हैं तो प्रकाश ही प्रकाश है।
Yes,
सज्जन
sir.
राजपुरोहित इज अ वेरी सीनियर मेडिकल ऑन्कोलॉजिस्ट एट मैक्स हॉस्पिटल। तो आप सज्जन बताओ।
बड़ी देर बाद हमें चेक पॉइंट इनहिबिटर रजिस्टर हुए थे, अब ये टीके आ गए।
सर ये ना मतलब ब्रांच ही ऐसी है सर, हर हमें ही रजिस्टर करना मुश्किल हो जाता है। हर 6 महीने में कुछ ना कुछ और आ जाता है नया। फिर डॉक्टर श्याम हमारे को पढ़ाते रहते हैं, सारी कॉन्फ्रेंस में यही पढ़ा रहे होते हैं।
अरे सुबह सुबह।
नहीं पर कल इन्होंने अच्छा मतलब किया कंट्रीब्यूट।
जी सर।
मेड ए बैलेंस, क्योंकि अदरवाइज वो ऐसा हो रहा था जैसे फिजिशियन वर्सेस सर्जन हो रहा था।
अरे सर वो तो हमेशा रहता ही है।
अब क्या क्या याद करें यार, हमें तो समझ नहीं आती।
और ये भी देखो कितने सारे हो गए। अगर कोई आप ये देखो FEGF पे देख लो कितने हैं अब ये।
सिनीटनी भी हमारे यहाँ, हमें तो अश्विनी अभी तो पता ही नहीं कि हमारे पेशेंट में किसी में यूज की कब की नहीं
पता नहीं। मैं रीनल सेल कार्सिनोमा में ये कहीं देते हैं शायद।
हैं डॉक्टर श्याम
देते हैं
आपने यूज की है हमारे पेशेंट में रीनल सेल कार्सिनोमा विद मेटास्टेसिस?
आपके थ्रू नहीं आते हैं, यूजुअली वो यूरोलॉजी के थ्रू आते हैं आफ्टर सर्जरी एंड ऑल। इसलिए आपका वो इसमें रोल
टच नहीं रहता, हमारा कांटेक्ट नहीं रहता उनसे।
हाँ राइट, दे आर नॉट इन योर फॉलो अप बिकॉज दे आर यूजुअली किडनी सेफ, यू नो।
बिल्कुल।
तो जब तक किडनी नहीं खराब होएगी वो जब क्रिएटिनिन नहीं बढ़ेगा वो आपके पास नहीं आएंगे।
वही है।
और सज्जन कैसा चल रहा है मैक्स?
सर ठीक चल रहा है सर।
बढ़िया। यू आर सेटिस्फाइड, यू आर हैप्पी?
सर आई एम हैप्पी। सेटिस्फेक्शन का तो कोई वो नहीं है, बट आई एम ऑलवेज हैप्पी, यू नो।
I know you are ever smiling, you know, always smiling.
Thank you sir, thank you sir.
I know. So Sajjan, how is your daycare doing?
सर अभी तो पिकअप कर रहा है, बीच में बंद कर दिया था सर उसको ना, अभी रीस्टार्ट किया है, 2 ही महीने में रीस्टार्ट किए। तो अभी तो सर वी आर डूइंग अराउंड लाइक 60 to 80 साइकिल्स पर मंथ, तो इट्स नॉट दैट गुड, बट देन आई थिंक इट विल टेक सम टाइम। वैशाली इज डूइंग गुड सर। वैशाली जो सेंटर है, जो नया उन्होंने बिल्डिंग बनाया है, आई थिंक दैट्स डूइंग वेरी गुड सर।
I think that's a very nice building they have.
Yes sir, definitely. That's a wonderful, मतलब सच में लगता है मैं उसी बिल्डिंग को देख के चला गया वहां पे। बिल्डिंग तो बड़ी अच्छी बनाई हुई है।
I think one of our colleagues' wife was admitted, so I just had a chance to visit him, you know. So I think
हाँ मतलब अच्छी बनाई है, सुंदर बनाई है इन लोगों ने काफी। सर टीम भी काफी ऐसा ऑन्को में तो काफी वहाँ पे कॉन्सेंट्रेट हो गया सर वैशाली में ना, मतलब इसमें तो एक तरह से
वो अपने दिनेश मित्र वही है डॉक्टर
दिनेश। जी सर वहीं पे है सर डॉक्टर दिनेश।
he is the head, I think.
Yes sir, he is the head of radiation oncology sir.
अच्छा तो उन्होंने अब क्या किया, अब अपना ही हॉस्पिटल ने डाल दिया ना, वो जो आउटसोर्स किया हुआ था वो खत्म हो गया।
हाँ सर, वो तो हो गए सर, 4 साल हो गए उसको खत्म हुए। मतलब वो पहले तो गैलेक्सी वालों को पुराने वाले मैक्स ने ले लिया था, अब वो पुराने वाले मैक्स को नए वाले मैक्स ने ले लिया था। वो तो मतलब अब इन्होंने सर बहुत बड़ी बिल्डिंग बना दी, मतलब ऑलमोस्ट ना 9 स्टोरी की बिल्डिंग बनाई हुई पीछे ऑन्कोलॉजी की। तो
बहुत
उसमें
ज्यादा
से अभी
रिक्वायरमेंट है। नहीं अभी देख तो डंडाराम भी मेरे ख्याल 2 साल रह जाएंगे, क्यों भी श्याम 2 साल?
हाँ, आई होप बिल्डिंग की थोड़ी वो तारें सी तो दिखनी शुरू हो गई वो।
नहीं नहीं नहीं
हाँ, बिल्कुल।
ये तो
नहीं, अब तो
बताओ,
हो रहे हैं,
हम पता नहीं
3
सर
फ्लोर हो
10
रहे
साल
हैं।
से सुन रहे हैं हम 10 साल से सुन रहे हैं बिल्डिंग बन रही है, बिल्डिंग बन रही है।
होएगा धीरे धीरे।
सर वो ना वो बोले एसिम्प्टोमेटिक विकास हो रहा है वहां पे, दिख नहीं रहा कुछ भी विकास हो रहा है, लेकिन
एसिम्प्टोमेटिक कोविड है ना।
नहीं,
ग्रेजुअली इट इज
ग्रेजुअली हो रहा है।
उसकी टेक्नोलॉजी देखो ना, बिल्डिंग कैसे बना रहे हैं, इट इज रियली अमेजिंग। हम तो रोज ऊपर से देखते हैं 4th फ्लोर से ना, हमारे पेशेंट है वहां पे, तो हमें तो
अच्छा
सारा नजर आता है कैसे वो मशीनों के साथ बने बनाए स्लैब्स फिक्स करते हैं।
अच्छा
और
सर,
पहले
नहीं
नीचे बेसमेंट कैसे बनाई उन्होंने, मतलब हमने तो शुरू से फाउंडेशन से देख रहे हैं इसको।
तब ऊपर से आपको
हाँ,
4th फ्लोर, राइट, आपका
4th
वो
फ्लोर से,
बिल्कुल उसके सामने है बिल्डिंग,
हाँ,
राइट।
तो बड़ा क्लियरली नजर आता है सर।
The Dr. Rana is trying to log in. Should we start? Or should we wait
बिल्कुल
for another?
नहीं, उनको क्या प्रॉब्लम है?
वो फैकल्टी लाउंज के थ्रू he was not able to get through with that. तो मैं कर रहा था उनके फोन पे।
कर रहे हो कि हाँ, बस कुछ नहीं, जब खोलो फैकल्टी आएगा बस एंटर कर दो, अपने आप आ जाता है। नहीं
राइट सर।
नहीं तो बोलना लैपटॉप पे इजी हो जाता है ना।
लैपटॉप पे ही कर रहे हैं सर। Should we start?
Yeah. Start.
गुड मॉर्निंग डॉक्टर नारायण प्रसाद।
Good morning, sir. How are you, sir?
बस बढ़िया, थैंक यू वेरी मच, वेलकम टू आवर अपडेट।
And yesterday also I have joined, sir. This was a great sessions.
थैंक यू।
You always do great show. Vedant is very much behind everyone and getting very good show.
थैंक यू सर।
That is very important here.
चलो बिना
Vedant, you can
Good morning
start.
everybody. Sorry sir. Sir कुछ कह रहे थे?
No, you can start now.
Right, thank you sir. Good morning everybody. So now after yesterday's exhaustive session in which we have covered very pertinent topics with exemplary chairpersons, panelists, and speakers. The topics were multiple myeloma, cancer and glomerular diseases, and panel discussion on use of upfront systemic chemotherapy versus upfront cytoreductive nephrectomy. We move on to this day on Sunday, where we will take you further to the next list of topics by yet another eminent list of speakers as well as chairpersons who are going to make this journey today into onconephrology, a very exciting one. The topics under discussion today are oncopharmacology, where we shall try to cover checkpoint inhibitors, VEGF inhibitors, their role in kidney diseases, in how they affect the kidneys, how they promote and how they also reduce the risk of cancers or prevention of progression of cancers. Also, we will also take you to CAR T cell therapies, hematopoietic stem cell transplantation and the effect on kidneys. We'll also be talking about diagnostic dilemmas on how to diagnose renal mass from the nephrologist as well as the urologist perspective. And to end it all, we will also talk about amyloidosis. So with this, I would like to begin the scientific session for today. And it is with great pleasure that I will invite honorable chairpersons for the next session. For this session, this is session number 5. And I would like to invite Dr. Sajjan Rajpurohit, who's the principal consultant, medical oncologist. He's working at Max Super Specialty Center, Noida. And Professor Ashwani Gupta, who's one of my mentors for several years. He's the co-chairman, Department of Nephrology, Sir Gangaram Hospital. And I've been trying to learn how to conduct conferences and how to get their flows done through Sir for a very long time. Dr. Sajjan, may I request you to kindly introduce our speaker, Dr. Shyam Agarwal, please.
Thank you, Dr. Vanant. And it is my proud privilege to introduce none other than Dr. Shyam Agrawal. And he's as popular in oncology circles as he is in Gangaram Hospital. And I can say he needs no introduction to any of my colleagues and peers. And he has always been very inspirational mentor and guide to all of us. Like you said about your guide. And he has been very academic, and throughout he has been mentoring us. And he is the head of Department of Medical Oncology at Sir Gangaram Hospital. And he'll be speaking on checkpoint inhibitors in genitourinary cancers. And this is a very important and fascinating area where all of us are moving ahead in cancer management. Over to you, sir.
Thank you, Sajjan, for the kind words. Thank you, Dr. Ashwini, for chairing the session. And of course, thanks to the organizers for giving me this opportunity to share my thoughts and the new data as it is evolving. So can I have my slides, please? Can the organizers share the slides? Okay, so the topic or the title which I've given, it's a mini revolution. And I think it's not only a mini revolution, it's a major revolution in the management of genitourinary cancers, especially so in the last 2 to 3 years. So it's a very, very rapidly evolving field, and things are changing extremely, extremely rapidly. So I'll show you in the next 15 to 20 minutes how it is happening. Next, please. So I'll basically, since this is not an oncology meet, so I'll take you through the statistics and the results of the immune checkpoint inhibitors in urothelial cancers and followed by kidney cancer. So this is just the projected, incidence of bladder cancer in India in 2020. So you can see here, so urinary system, nearly, 33,000 cases, and kidney, 12,000 cases. And in women, 11,000 and 5,000 cases. So, that is the kind of estimated number of cases which we see. And you see the bladder cancer, majority are transitional cell. And these immune checkpoint inhibitors, which we're going to be talking about, are focused on transitional cell. Next, please. Next slide, yeah. So, just to see the distribution from Tata Memorial in 2013. So urinary bladder cancer, if you see, non-muscle invasive cancers are sort of ruled out from our domain, from the domain of medical oncologists, which are like 50%. And in patients with muscle invasive or metastatic disease, that is where systemic therapy comes in, where these immune checkpoint inhibitors are to be used. Next, please. So this is a little busy slide to demonstrate that, we are only interested in patients who are having muscle invasive, locoregional, or patients with metastatic disease, where the role of cisplatinum based therapy, or now we are calling these PD-1 or PD-L1 inhibitors, which are the immune checkpoint inhibitors, we are going to be using. So nearly 50% of the urinary bladder or the urothelial cancers where we have the role of these checkpoint inhibitors. Next. So I'll skip this slide. So where should we use? What are the indications? So that is where I'll just come to. Next, please. Okay, so as I said, local disease dealt by urologist, and locally advanced or metastatic disease by the medical oncologist or radiation oncologist. Next. Next slide, please. So basically now, first, right. So can we go to the previous slide? Okay, so first line treatment for metastatic urothelial cancer used to be, or perhaps still is, cancer chemotherapy, which is cisplatinum based. So, these are the criteria. So a patient with bladder tumor, as you nephrologists would understand, would, a lot of times have effect on the creatinine clearance or the creatinine levels. So, but there is a huge issue for patients with urothelial cancer who have low creatinine clearance, especially less than 60 or less than 30, which I'll just allude to. And a lot of these patients, when they're exposed to chemotherapy, or elderly patients, well, they have hearing issues and neuropathy because of diabetes, where the cisplatinum-based chemotherapy has difficulties because that is a side effect of this chemotherapy. So those are the issues we are faced with in patients with metastatic urothelial cancer. Next, please. So this is the timeline as you see. So cisplatinum gemcite we saw from 2000, and now you see in 2016 and 17 a huge list of these drugs, which for perhaps nephrologists difficult to memorize or to even verbalize, like atezolizumab, durvalumab, evolumab, nivolumab, and pembrolizumab. And just to say in the onset, 4 of these drugs are readily available to us today in the market, and we are using them for our patients with urothelial cancer. So that is how there is a huge kind of revolution which is happening in this field. Next slide, please. So now what is the data? Where are we using these drugs? So this is the treatment landscape in one slide, where anti-PD-1, I'll show you one slide on PD-1 and PD-L1 for metastatic bladder cancer. So as I said, there are 5 agents and 4 of those are available to us. So they're approved in second line, which means that first line still is cancer chemotherapy, which is platinum based, or gemcitabine combination is used. But also 2 of them are used in the first line, especially if the patient is platinum ineligible, which I just described, that a patient who has a creatinine clearance less than 30, or who has a poor performance status, or patient has a neuropathy, etc. So where a patient is platinum ineligible, there you can use drugs like pembrolizumab and atezolizumab in first line in patients who have disease which is metastatic. So, so these 5 drugs are available. So what is the data now? So these drugs are available not only for second line use after chemo failure, but also for first line in platinum ineligible. Next, please. Okay, so this is the NCCN 2020 guideline. As you see, for cisplatinum eligible, it is chemotherapy. For cisplatinum ineligible, it is atezolizumab and pembrolizumab. And I think second line, of course, these drugs are readily available. Next, please. So now looking at a little bit of data in detail. So now you see the chemotherapy, which is cisplatinum based, gemcitabine based, you see 49% respond and the survival is around 14 months. So which is not good at all. And it's a huge unmet need. Next, please. Okay, so these are the platinum, based chemotherapy eligibility. So, these are the issues patients face, especially creatinine clearance or neuropathy, or their heart is not good because some are elderly, their performance status is poor. So these are the criteria for platinum-based therapy. And if you do not fulfill these criteria, well, then you can use atezolizumab, which is readily available to us in the first line. Next, please. So, treatment outcomes with chemotherapy, I've already mentioned. So it's nearly, the survival is to the tune of 14 months and, so which is not good. The other therapy which we used to use before was MVAC, which is very high dose MVAC, which is very, very toxic and people don't prefer using it. Next, please. So, I've explained to you, but I'll begin with another thing which has just happened in the last few months, which is the role of maintenance therapy, which means that you've treated your patient with cisplatinum or carboplatinum and gemcitabine, and we were just leaving them alone. So very promising data has emerged in the last few months, which is after the patients have a partial response, some residual disease is there, then you can maintain that with the immune checkpoint inhibitor like evolumab. So I'll show you that data. Next, please. So I think I'll just skip this slide. Next. So this is one slide I'm taking showing you regarding the PD-1, PD-L1 interaction. So you see PD-L1 is expressed on tumor cell, and the T cell, which is supposed to kill the tumor cell, is although there, but it is lying dormant. And that is because of the interaction of PD-L1 on the tumor cell and PD-1 on the T cell. So because of this interaction, there is a suppression of the T cell. These antibodies, whether they are PD-1 antibodies or PD-L1 antibodies, which I just showed you 5 of them, so they break this nexus between PD-1 and PD-L1. And because of this breakdown, the T cells become active and they can then, kill the tumor cell. And that is how these patients derive the benefit. So this is in very, very simple, terms to explain that although the T cells are there, as you know, the lymphocytes are there when you do a biopsy, when you do a tumor resection. So it's a mixture of T cells and tumor cells, but these T cells are inactive because of this PD-1 and PD-L1 interaction. And these drugs, immune checkpoint inhibitors, so they break this nexus and make these T cells active to kill the tumor cell. Next, please. So this is the maintenance study where called the Javelin study, avelumab in patients. Can I have the next slide? So this is the avelumab study, which clearly shows you the overall survival benefit. You can see the p values being 0.001, hazard ratio 0.69 as compared to placebo. So there were two groups of patients after chemotherapy, avelumab versus best supportive care. And since the hazard ratio and the p value is favorable, I think this drug has been approved in the US. This is not available to us, but I'm sure it's going to be launched in the next 2-3 months. That's what I'm being told by the Merck. Next, please. So again, this is again a detailed study to show that all groups of patients tend to derive benefit from avelumab in the maintenance. So this is after chemotherapy. Next, please. So now, what about the first line? As I told you, that patients who are not eligible for platinum-based chemo. So what is the data there? Next. So you see here that this is the number of the study 210 in first line platinum ineligible. And you see, very interesting, 2-year survival is 41%. So the curve is plateauing. And you see, these are the immune cell status. They do the PD-L1 testing, etc. But you see all the patients, irrespective of the immune cell PD-L1 expression, you see nearly 23% patients are responding. But it's a very interesting feature of these immune checkpoint inhibitors that patients who respond, well, they're a plateauing of curve. So with chemotherapy and with, I'll come to sunitinib in the RCC, patients will die in 2 to 3 years. But patients who survive, and let me just say here, I have 3 patients on immune checkpoint inhibitors in bladder tumor who had failed chemotherapy and now living beyond 1 to 2 years. They just go on and on and on. And I think our chairperson, Sajjan Rajpurohit, can also, share his thoughts on the role of these immune checkpoint inhibitors. And you see, the curve is not, coming down, which means that the patients are dying. Here, patients are actually not dying. So 2-year overall survival is 41%. And this is extremely, extremely amazing. And that is the beauty of these immune checkpoint inhibitors, not only in bladder cancer, but all tumors. So if you get a response and if you have a survival, these patients are likely to live for long periods of time. And in lung cancer, in bladder tumors, etc. So 5-year survival is touching to 20% or 30%, which was unheard of in the chemotherapy in the targeted therapy era. Next, please. So this is atezolizumab. This is pembrolizumab. You see a similar curve where the curve is plateauing at 20% or 30% at 40 months, which is something like 3 to 4 years. So this is an amazing success story for bladder cancer patients who are not supposed to live for that long. Next, please. So now people want to combine atezolizumab or these immune checkpoint inhibitors with chemo in the first line. And there is encouraging data, but we don't have approvals. Next, please. So, there are some encouraging results, but I think that needs to be tested still further before we can move checkpoint inhibitors along with chemotherapy in a bladder tumor. Next, please. So second and subsequent lines, I think that is where we are using these drugs more frequently. Next, please. So this is a summary slide to show you can still get complete responses, 6 to 7% with these drugs like atezo, pembro, nivo. They're all readily available. And you see the response rates are to the tune of 20%. And you see the 12-month overall survival is 37% or 43%. So this is in second line after the patients have failed chemotherapy. Next, please. So this is a cross-trial comparison showing that these drugs do work in several phase 3 trials after the failure of chemotherapy. Next. Okay, so that was, talking about the urothelial cancers. They should have transitional cell carcinoma, so you can use them in first line cisplatinum ineligible, in second line after chemotherapy failure, and once avelumab is available in the maintenance setting. So what about metastatic RCC, which is again a huge unmet need? Next, please. So, these are the figures in various countries, huge load. What about India? Next. So you can see, the number of patients here in various age groups, and the mortality is there. The total number of patients which we see in India is around 10,000 for kidney cancers in the metastatic setting. Next, please, or even more, 15,000. And that's the survival. Survival is good in stage 1, 2, but when you come to stage 3 and 4, distant metastasis, it's hardly 12%. So again, a huge unmet need. And but you do see a large number of these patients. Next. So this, I think, was discussed yesterday, that these are the criteria which define the low risk, intermediate risk, and the high risk category. These are the LDH levels or hemoglobin levels, correct calcium level, and various factors which we need to understand before we decide favorable, intermediate, and poor risk. Next. So again, this is what we were discussing before, that TKIs were the main thing, which are the tyrosine kinase inhibitors, which inhibit mainly angiogenesis. The drugs like sunitinib and pazopanib are actually still the most important agents, because these immune checkpoint inhibitors are extremely expensive, and I think majority of the Indian population is not able to afford. But yes, we are seeing patients who can afford. And you can see the risk stratification. Favorable risk 30%, intermediate risk 35%, and poor risk is 35%. So these are high risk patients or intermediate risk patients where we are actually requiring newer drugs like pembrolizumab and avelumab, which I'll just show the data to you. Next, please. Can I have the next slide, please? So sunitinib and pazopanib, which are the multiple tyrosine kinase inhibitors, they take you to about 2 years or 3 years at the most in most of the patients. And this is the timeline for the discovery of these drugs. So 2006, we had sunitinib, and now you can see again 2015, 16, 17 onwards, nivolumab, ipilimumab, pembrolizumab have been, these are approvals, by the US FDA, and they've come in the NCCN guidelines. So you can see this is a summary slide to show that in standard risk or in favorable risk, we can still use drugs like sunitinib. But when it comes to intermediate and poor risk, you don't find sunitinib, this is just a poor man's drug at this point in time, because we have these 3 combinations, which are, we call them IO drugs, immune oncology drugs, or immune checkpoint inhibitors. So this is IO. The 2 IO drugs, pembro and exitinib, and avelumab and exitinib, which is a combination of TKI and immune checkpoint inhibitor. So this has become the standard of care, and these have Indian approval. The DCGI has given the approval to these combinations, but the problem is the cost factor. Next, please. So what is the data there? Next. So again, a summary slide to show that in favorable risk, you have the availability of sunitinib, but then in poor and intermediate risk, you want to use these immune checkpoint inhibitors if somebody can afford. But if you cannot afford, then you have no choice but to use sunitinib or drugs like pazopanib. Next, please. So I think these are again the same slides. Next slide, please. I'll show you the data as it stands. So what is the data here from the previous studies? You can see, as I told you, that the response rates are 25%. Complete response rate is very little, 1% or even less. And the median overall survival is, as I said, 2 to 3 years with drugs like sunitinib. So these are the 2 drugs which are commonly used in day-to-day practice. Now just see the last slide where you are using these immune checkpoint inhibitors, IO combination, nivolumab, ipilimumab, and you see the response rates jumps to 42%, the complete response jumps to 9%, and you see the overall survival is not reported at the time point, so which is even better than 29 months. So I'll show you more slides on the TKI and the IO combination. Next, please. So these trials are done usually in the clear cell setting. I'll not go into the details, it's a little busy slide, but I think these are the 2 trials, which is the Javelin 101, which has seen the approval of avelumab and exitinib, and the Keynote 426, which has seen the approval of pembro and exitinib. So those are the 2 key combinations along with IO, because I think ipilimumab is going to be launched in India very soon. So we need to keep an eye on this. Next, please. So as I said, these are the 2 studies, Javelin 101 and Keynote 426. And you see here that, these are the number of, this is the, demographics, patient characteristics. I think we'll go to the data. Next. the results. So this is Javelin 101 and Keynote 426. And as I showed you in the previous slide, the complete response rates are beginning to show up here, 5.8%, 3%, and 11%. And you see the response rates jumping to 41%, 51%, 60%, which means that there's a shrinkage of tumor in a considerable number of patients, which was not happening with drugs like sunitinib. And the median overall survival is not being reported. If you look at the progression-free survival, 13.8 months or 15 months, which is better than sunitinib, which was the comparator arm here. So because of these results, these two combinations, or rather three combinations, have seen the approval of these drugs in metastatic RCC setting, because they're statistically significant. In overall survival, you see 0.0003, 0.06 here, but 0.0001. So because of the statistical significance, these combinations of TKI and immune checkpoint inhibitors have been approved. Next, please. In the first line setting, if somebody can afford. Next. So I think now coming to a little bit about safety, which was being discussed. So I just want to focus. Actually, this is not a single drug. You see, Keynote is a combination of TKI, because TKI is going to give some toxicity. But if you just look at the numbers here, the incidence of toxicity is so small. You see 3%, 5%, it's less than 10%. So these drugs are extremely, extremely well tolerated. And therefore, but you have to be still extremely careful, because immune checkpoint inhibitors can result in the activation of T cells in any organ, in any part of the body. And you can see toxicity in the kidney, in the GI, and so on, So, you have to be extremely, extremely careful. Hypothyroidism is an important side effect, which we need to remember. So I think these are detailed studies. I'll skip these studies in the interest of time. Next, please. Next. I'll go to the last couple of slides. Next slide, please. Because I think I've conveyed the essence of the message here, that these drugs are extremely powerful, potent, and giving you long-term results. Next, please. Can you go to the next slide, please? So I think there is some issue there in moving the slide. I think go to the summary slide to show that these immune checkpoint inhibitors are actually the fifth pillar of cancer treatment today. The first being surgery, second being radiation, third being chemo, and fourth being TKIs, or the targeted drug. So immune checkpoint inhibitors, the last slide, I think we can finish this off. Next slide, please. Can you go to the next slide? Which is what I was quoting from. And I think we can skip the slide if there is a difficulty there. So immune checkpoint inhibitors are approved almost 15 cancers, and RCC and urothelial cancer are two such cancers. And these are going to stay for almost ever now in the next 10, 15 years. And various combinations are going to be tried along with chemotherapy, along with TKIs, and IO combinations are there. And in urothelial cancers, you can use in first line, cisplatin ineligible, use in second line, or use in maintenance therapy. As regards metastatic RCC, you can use in first line. There's a clear approval in combination with TKI, and in second line, definitely where the TKI has failed. So I think these drugs are going to stay in the armamentarium of the medical oncologists for long now. And we are very fortunate to be in this era of immune checkpoint inhibitors, because long-term survivals, which were not seen before, are being seen now in 20%, 30%, which is a sizable number. And this number is going to increase as we address more combinations with immune checkpoint inhibitors. So I think with this, I can close here and thank everybody for their patient listening and for giving me this opportunity to share these new thoughts. Thank you very much.
Thank you, sir. May I request Dr. Sujan to kindly ask questions?
So actually, sir, as sir has rightly mentioned, that immune checkpoint inhibitors are the new drugs which have added to the armamentarium of our fight against at least advanced cancers, yes. But sir, what about the adjuvant or the new adjuvant strategies, which how will they benefit or they will impact in the near future? What do you feel is the role of these in especially neoadjuvant as well as in adjuvant settings?
Right, your question is quite valid, because the response rates are 50, 60%. So, that is an extremely, extremely encouraging sign there. I think the trials are on. We are seeing some encouraging results in lung cancer and in colon cancer, especially in patients who are, MSI high, as you know. So I think you have to select out that population of patients where you have PD-L1 overexpression or IC overexpression. And I think absolutely it's a way to go. This story is just unfolding. It's only 2, 3, 4 years, I mean, so
Yes,
I
sir.
think we have these immune checkpoint inhibitors, though expensive drugs, but I think it's too early at this point in time to have data there for the adjuvant and the neoadjuvant setting. So can I see a question here from Dr. Bhalla. Is BCG installation act like immune checkpoint inhibitors in bladder cancer? Yes, so BCG is basically, these are attenuated BCG, like mycobacteria, which are instilled in the bladder. So they get into the bladder epithelium and they stimulate the immune cells to kill the cancer cells in the urinary bladder. So that is the mechanism of action of BCG but it only is in the superficial bladder cancer. It doesn't work. It is not effective in invasive bladder cancer, because it cannot infiltrate into the bladder, into deep, or into the blood vessels. And that is, we actually don't want the BCG to go into the blood vessels, because it can then cause tuberculosis, which could be fatal for patients with bladder tumor.
I think that's very meaningful, sir. And thank you so much for such wonderful presentation, sir.
Dr. Sham, can I ask you one question? What is the indication of these immune or targeted therapies? Do every patient require, or you give it in certain situations?
Yeah, so it's a good question. I think all these drugs at the moment are indicated only in metastatic setting. So when the patient have spread of the cancer into other organs, or patients are inoperable for whatever reason, and because for inoperable radiation, for localized disease, radiation is still an answer. But patients who have had disease which is spread to bones or to lungs or to liver, so that is where the role of these immune checkpoint inhibitors or systemic therapy is there. So I think it is only meant for patients with metastatic disease who are not possible to operate, or who are not able to get radiation to get rid of the tumor, especially for the bladder tumor, because kidney tumor is radio resistant. RCC is radio resistant. RCC is chemo resistant. That is why we never discussed chemotherapy today. They're only sensitive to TKIs like sunitinib and pazopanib, and now we do have the data on immune checkpoint inhibitors. I think Anil has asked a question: can we avoid radical cystectomy today? This is a question for localized bladder cancer. There is interesting data, encouraging data, maybe Sajjan can take it, that chemo radiation
Yes,
is
sir.
an
So,
option.
yeah.
Actually,
Actually, I think there's more and more role of chemo radiation now, which is coming up. And probably next 2 years or so, we'll actually have a lot of patients going for chemo radiation. So for long, radical cystectomy has been there as a standard of care. But I think that the data which is coming up with especially with the doublet agent chemotherapy along with the radiation is very promising, and that offers a bladder preservation approach. And I think many of us are actually nowadays opting for this approach from our patients, especially who are especially elderly or who are not willing for surgical this thing.
Right. So I think the so far the whole world still wants to operate on all the patients who have invasive cancer of the bladder. Cystectomy or radical cystectomy is the answer. But yes, there is a school of thought. If you look at the survival curves, they're actually almost matching the surgery. But it's very difficult to evade surgeons today because they have a huge lobby. And of course, radiation are also not lagging behind. But there is a debate. But then, as Sajjan said, if patient is not fit for surgery for whatever reason, so radiation and chemo may not be a bad option, because cures are possible in patients who have disease which is confined to the urinary bladder.
So if we have no more questions, can we move on to the next talk?
Thank you.
Thank you very much, sir. Dr. Ashwini, sir, can you please initiate proceedings, sir?
Okay, thank you, Vinant. And it's really an honor to chair the session. And really, I have been very wiser once you gave me this topic and I could read something. And Dr. Shyam Agarwal and now Dr. Sandeep Mahajan, they are further going to enlighten all of us. And it has been really a very fascinating and informative talk by Professor Shyam Agarwal. And in last 2 days, we have seen that medical oncology has undergone a sea change, a javelin throw, as mentioned by Dr. Shyam Agarwal, in the pharmacological treatment of cancers with the advent of these targeted therapies. So everything comes with a cost. So no doubt these drugs are costly, but there are certain side effects. And to discuss these, especially effects on the kidneys, we have Professor Sandeep Mahajan, who will discuss the nephrotoxicity of CPIs and VEGFR. And Professor Mahajan does not require any introduction. He is a professor of nephrology at All India Institute of Medical Sciences. He has done pioneering works on CAPD, glomerulonephritis, and had been involved in a lot of philanthropic work. And I have great pleasure in inviting Professor Sandeep Agarwal, Sandeep Mahajan to deliver his talk.
Well,
Professor Sandeep Mahajan.
thank you very much, sir. And thank you for giving me the opportunity to be here. And as Dr. Ashwini Gupta said, we have been wiser with this topic because this is one area which we don't usually encounter very frequently. So Dr. Shyam actually has made my job easier by taking us to the priority these agents have in current oncology setting. So the downside or the flip side, as has been mentioned in the title, is overcoming the inevitable nephrotoxicity. So we will discuss briefly about these agents and how they can be nephrotoxic. Though it's not inevitable, it's still a rare complication, as Dr. Agarwal said. So we just start with two case summaries dealing with each of these agents. This is a 58-year-old gentleman who had been hypertensive on calcium channel blockers, detected having adenocarcinoma of left lung, underwent a lobectomy in 2018, and had unfortunately had a recurrence a year later, for which he underwent a partial VATS resection, and subsequently was started on an anti-PD-1 agent. And 4 months later, from a baseline normal KFT, his creatinine rose to 2 grams a day, 2 milligrams per deciliter, and in 2 weeks it rose to 8 milligram per deciliter, necessitating the need for discontinuation of the drug and starting of renal replacement therapy. And we performed a renal biopsy. The second case is again of a 54-year-old gentleman who was controlled on amlodipine 10 milligrams a day. He had a carcinoma rectum for which he underwent a left colectomy in March 18, and on routine evaluation again was unfortunately detected to have liver mets. He was started on aflibercept, which is basically an anti-VEGF inhibitor, along with 5-fluorouracil. He had a increase in blood pressure requiring uptitration of antihypertensives 3 months subsequently, which was still poorly controlled, and then had a rise in creatinine along with nephrotic rich proteinuria, for which our consult was sought. So these two cases actually highlight the potential problem these patients have, these drugs can have for the nephrologist. And as Dr. Shyam was alluding to, in last 3 or 4 years, there has been a rapid increase in the use of checkpoint inhibitors in oncology practice. And this actually, following this curve, it's quite obvious that over the years, this is bound to increase. And this is just what is the current status of USD approval for immune checkpoint inhibitors as a therapy. And you can see this practically covers the whole spectrum of oncological tumors. And as Dr. Shyam had already highlighted, these drugs are here to stay and to grow. In fact, the number of patients being treated with immune checkpoint inhibitors is growing because this is now being approved both as a monotherapy and as well as in combination with other chemotherapeutic agents. Initially, they had been used, as you said, for predominantly metastatic diseases, but they are now getting increasing approval for even earlier onset of diseases and earlier therapies. And as he said, that though initially the optimal duration of these therapy is not actually known, and patients have been on these drugs for more than 2 years now. So obviously, as their use and the duration of their use increases, we are likely to encounter the problems associated with these drugs more frequently. The major problem or the major limitation of immune checkpoint inhibitors is what they call as immune-related adverse events. And this is quite obvious if we know that the mechanism of action of these drugs is loss of self-tolerance and excessive immune response. This is how these drugs act, and this is how they are likely to cause adverse events as well. So just a brief slide as to how these drugs act. These drugs can act at a central level, at the level of the lymph node, where the antigen presenting cells interfaces with the T cells, and there, once the T cell is activated, CTLF4, which is actually an inhibitor, is from the lysosomes peripheralized and expressed on the cell, and here it interacts with the same co-stimulator pathway which we use so frequently in renal transplant. And by blocking this co-stimulation pathway, by inhibiting this interaction of CTLA4 with the CD80, it actually enhances the co-stimulation pathway and therefore can lead on to non-apoptosis of this T cell, and this can lead on to further mounting of immune response against these cancer cells. On the peripheral tissue, the immune cells actually, the tumor cells actually inhibit the express PD1, and this can lead on to apoptosis of the activated T cell, and this prolongs the life of the tumor cell. The immune checkpoint inhibitors, by blocking either the PD-L1, which is expressed by the cancer cell, or by blocking PD-1, can inhibit this interaction and therefore immortalize and therefore lead on to destruction of this tumor cell. However, on the flip side, the PD-L1, which is also expressed by various epithelial cells, including the renal tubular epithelium, then gets exposed to the higher interaction of higher attention of this activated T cells, leading on to the tubular injury. So this is the various spectrum of immune-related adverse events, predominantly skin, thyroiditis, lung involvement, and esophageal involvement. Renal involvement, as mentioned here as nephritis and vasculitis, is again rare, but still an important side effect. So a meta-analysis which looked at the use of various immune checkpoint inhibitors, having around 3,700 patients, found renal incidence of acute kidney injury of around 2.2% and severe acute kidney injury of only 0.6%. However, once we talk about combination therapy, the incidence rose to about 5%. The clinical features predominantly was rising serum creatinine, which obviously was the inclusion or detection criteria for almost all these adverse events. The urinary findings predominantly were pyuria, hematuria, worsening proteinuria, and serum eosinophilia was found in majority of patients. However, the classic triad of acute interstitial nephritis, that is skin rash, eosinophiluria, eosinophilia, is actually present in only a small minority, around 1/3 of the patients. So they basically present with an atypical presentation of interstitial nephritis. The recent real-world data, however, shows the incidence might be much higher, around 10 to 30%. Well, this is a very recent article which was published in CJASN, which basically was from Massachusetts, which looked at around 1,000 patients in which from 2011 to 2016, they had given immune checkpoint inhibitors, and most of them had a normal renal function. They followed up these patients for 12 months. And what they found was that ill-sustained acute kidney injury, that is some rise in serum creatinine value, which was not of acute kidney injury, was in 17%. Only around 8% had a acute kidney injury, which was sustained beyond 72 hours. And the checkpoint associated acute kidney injury was seen in around 3% cases. The associated risk factors were use of proton pump inhibitors, which increased the incidence of acute kidney injury to around 2.8 times. So if we have combination of other nephrotoxic drugs along with checkpoint inhibitors, the toxicity of these drugs increase. However, as nephrologists, we always contend that acute kidney injury in this set of patients is poorly looked at. If you look at studies prior to 2016 and 17, the acute kidney injury was defined very loosely as some rise in serum creatinine, or there was just mentioned that these many patients had rise in creatinine. So there was huge reluctance from the oncologists to actually adopt the standard criteria for acute kidney injury till 2016 or 17. We should also understand that these patients are remarkably malnourished, sarcopenic and cachexic, and therefore the serum creatinine values at the baseline would be much lower than you would expect from a normal person. And also the standard equations which we use for estimated GFR needs actually correlate very poorly with the measured GFR values. There has been a study which has looked into it. And obviously, this small study did suggest that we should have a better marker or better measurement or better equations for having an estimated GFR from serum creatinine values. Various other markers have also been looked at, but none have been found to be useful, especially cystatin C, which can be increased in malignancy. The delayed presentation is another problem for the renal adverse events of immune checkpoint inhibitors. The median is around 14 weeks, as opposed to around 4 weeks for most other immune-related adverse events. So that's why acute kidney injury is probably underrepresented. So what can be the mechanisms of nephrotoxicity? The most obvious one, as I told, could be because of the immortalization of T cells. It can lead on to autoantibody production, which can lead on to renal damage. As I said, the renal tubular epithelial cells, especially the tubular cells, do express PDL1, by which they escape the damage from activated T cells. However, once we use anti-PDL1 agents, you can have an off-target effect of acute tubular injury. Another important way is cross-reactivity with the normal host antigens, which can occur both in the endothelium as well as the epithelium. This can lead on to endothelial or epithelial damage. Another very interesting and a unique mechanism which can occur with nephrotoxicity is that it can lead on to suppression of the inhibition, which normally acts on the T and B cells, which suppresses the formation of drug-induced antibodies. So various drugs, whether that be proton pump inhibitors, NSAIDs, and antibiotics, which are used very frequently in general population, the antibodies or acute interstitial nephritis is actually suppressed by various defense mechanism against these T and B cells. But once we use immune checkpoint inhibitors, it can lead on to propagation of these normally dormant T and B cell lines, leading on to acute interstitial nephritis like picture, which could be because of reactivation of these drug-specific effector T cells. And this, as I said, classically occurs much later as opposed to the common drug-induced acute interstitial nephritis, which occurs in weeks. So this can occur even after months of use of a particular agent. So what is the renal histology? This is a recent publication in which they looked at around 70 renal biopsies performed in patients with immune checkpoint inhibitors. Acute tubular interstitial nephritis alone or with a combination of acute tubular injury accounted for majority, around 41. In around 10 patients, there was a combination of acute tubular interstitial nephritis along with a glomerular disease. Prominent among them were the MCDs, the MGNs, the MPGNs, and the FSGS, along with the case of C3GN and IgA nephropathy. If we look at the glomerular disease alone, this occurred in around 9 patients. And again, the combination was SLE like membranous disease, MCDs, FSGS. So predominantly podocytopathies along with IgA nephropathy in a few cases. Acute tubular injury alone also occurred in few patients along with the case of TMA. So this can be the spectrum of glomerular diseases which occurs with immune checkpoint inhibitors. The most frequent of that is acute tubular interstitial nephritis. So this study from Jason, which has been just published a month ago, again looked at the clinical features and outcomes of immune checkpoint inhibitors in a multi-centric study. So in a multi-centric study involving centers from Europe and US, what they found was they took around 138 patients who had immune checkpoint inhibitor associated acute kidney injury, which again was defined as more than 2-fold increase in serum creatinine or dialysis requirement, again a very vague definition. And they collected 276 control patients who received the drugs but did not develop acute kidney injury as controls. What they found was that if the patient had a borderline decrease in GFR, that is a borderline decrease in GFR, concomitant use of proton pump inhibitors, and if they used a combination of immune checkpoint inhibitors, like using of CTLA-4 agents along with the PD-L1 agents, there were higher chances of having nephrotoxicity to the tune of 1.5 times to 4 times. If they also looked at the severity of acute kidney injury, and they found that majority of patients actually had a severe acute kidney injury, and the peak creatinine was to the tune of around 4. And again, if they look at the frequency of association of acute kidney injury along with other immune-related adverse events, there was a poor correlation with them, with only around 40% of patients having previous or concomitant immune-associated adverse events. And commonest of them were rashes and other non-specified immune-related adverse events. Fortunately, a good majority of these patients at least had a partial to complete recovery, and only a minority, around 15%, didn't have any recovery. And the patients who were treated with glucocorticoids and the patients who were using especially proton pump inhibitors, discontinuation of proton pump inhibitors and use of glucocorticoids actually improved the outcomes significantly. So this is, in this study, what they had a course. As I said, only a minority of patients didn't have a complete recovery, and majority of them were treated with steroids with a good response. So coming on to the second set of agents which I have to discuss today, and that is anti-VEGF agents and its nephrotoxicity. Angiogenesis was mediated by vascular endothelial growth factor, is the main mechanism of metastatic tumor growth, and therefore has been an important target for cancer treatment for a very long time, as Dr. Agarwal had said. And new agents are being added each day, again increasing the chances of toxicities. Vascular endothelial growth factor, we all know, is an important receptor which is used for fetal as well as adult development. In adult patient, the VEGF is basically expressed on various vascular tissues. Important among them is the renal tissue, where VEGF has both a paracrine as well as an endocrine role. VEGF is released by podocytes and tubular epithelial cells, and VEGF type 2 receptors are predominantly found in mesangium, podocytes, glomerular, and peritubular capillaries. So this diagram here basically shows the tight paracrine and endocrine mechanism of VEGF in the glomerulus. As we can see in the podocytes, we have expression of VEGF, and we have VEGF receptors in the endothelium. This is where various anti-VEGF agents act. They could be predominantly VEGF antibodies. They could be agents which sequester the vascular endothelial growth factor. We can have tyrosine kinase inhibitors, which are downstream, which are basically deactivate the vascular endothelial growth factor receptor, as Dr. Agarwal told us about. And we can have various downstream agents, which could be BRAF antibodies or which could be mTOR inhibitors. So these are the agents which basically act on the VEGF axis. So either they could be antibodies, they could be sequestering agents, they could be tyrosine kinase inhibitors, or they could be various downstream agents like MKCs, BRAFs, and mTOR inhibitors. Now, coming on to this interesting interaction of the podocytes and the endothelial cells with the vascular endothelial growth factor. As I said, podocytes both express the receptor as well as secrete vascular endothelial growth factors. So this is basically required for regulation of inflammation, for maintenance of podocyte cytoskeleton, for survival of podocytes, as well as repair of podocytes. While in the vascular endothelium, these are basically required for the vasodilatation, the prevention of thrombosis, the angiogenesis, and various trophic effects on the endothelium. So once we have an inhibition, we can have a disruption of the cytoskeleton leading on to podocyte foot process effacement leading on to proteinuria. We can have decreased survival and shedding of podocytes. We can have pro-inflammatory cytokines, especially nuclear factor kappa B, which can subsequently lead on to fibrosis. In the endothelium, we can have a decrease in angiogenesis, we can have decreased trophic effects, and we can have endothelial damage, which can lead on to thrombosis and thrombotic microangiopathy. So which agent we use can have preferential side effect. If we use anti-VEGF ligand inhibitors, we can have predominantly thrombotic microangiopathy and nuclear factor kappa B, which can lead on to fibrosis. And if we use tyrosine kinase inhibitors, we can have predominantly podocytopathies like MCDs, membranous, of FSGS. Hypertension, however, remains the most common renal associated adverse events of these agents. High-grade hypertension is seen in around 18%, and this is mediated by decrease in NO synthesis as well as increased oxidative stress. And we have a higher incidence with pre-existing hypertension. Proteinuria, as I said, can occur both because of podocytopathy as well as hypertension and increased intraglomerular pressure. TMA can occur in a set of agents, and this can be, this is actually renal limited TMA, which is not dose dependent and occurs after variable period of initiation of these drugs. They basically present with worsening proteinuria and renal dysfunction. Systemic signs of TMA like thrombocytopenia, schistocytes, and raised LDH are actually seen in only 40%. So it's a predominantly renal mediated TMA with these agents. So coming on to the management, for all management basically of immune checkpoint inhibitors and anti-VEGF agents, there are basically 5 pillars of management. First is to have prevent the disease, that is to have high risk population and identify them. To anticipate by doing regular checkups so that we are able to catch these patients early. To be able to detect these by noting any change in the lab parameters we have. The treatment is predominantly by either discontinuation or use of immunotherapy. Reintroduction of these agents if required, and monitoring again forms the 5th pillar. So for prevention, we have to basically look at the identification of high-risk patients. They are predominantly elderly, female gender, patients having other comorbidities like hypertension, diabetes, and renal dysfunction, patients having hypoalbuminemia, and concomitant drug use, especially the proton pump inhibitors and the NSAIDs. We have to take a look at the blood pressure, monitor the blood pressure, especially with the anti-VEGF therapy, and we have to closely monitor them for 4 weeks and then maybe after every 2 weeks. The kidney function test using the CKD epi equation till the better equations are available. Urine analysis and quantification of proteinuria. Ruling out the other causes of acute kidney injury. Management of blood pressure. discontinuation of drugs with severe renal in patients with severe dysfunction, deteriorating renal function, and heavy proteinuria, and use of immunosuppressive agents. So this is just a flow chart as to show how we should go around managing these patients. In patients who have severe acute kidney injury, low-grade proteinuria, we just need a closer follow-up, and we might continue with these drugs. In case the renal function deteriorates further or proteinuria increases further, we can either discontinue the drug or do a kidney biopsy if indicated. And if the kidney biopsy shows acute tubular interstitial nephritis, treat them with steroids and discontinuation of drug, and treat any alternative diagnosis which comes as and when. So what happened to the patient? For the first patient, we did a biopsy. He had acute tubular interstitial nephritis. We treated with 1 milligram per kg of steroids along with discontinuation of drug. There was gradual stabilization of creatinine, and steroids were tapered in 4 months. There was no reintroduction of the agent, however. In the second patient who had poor BP control along with heavy proteinuria, we could not do a biopsy because of the poor patient performance. We did optimize the blood pressure, we did discontinue the drug and gave a trial of steroids. There was slight decrease in proteinuria, though it was still in nephrotic range with stabilization of creatinine. The patient unfortunately succumbed to the ongoing malignancy. So just to conclude my talk, checkpoint inhibitors have led to paradigm shift in anti-cancer therapy. Renal immune-related adverse events, though are less common, are a troublesome problem and are independently associated with morbidity as well as mortality. Acute tubular interstitial nephritis remains the commonest pathology. However, we should have an open mind as far as TMA, podocytopathies, and infection-associated glomerulonephritis are concerned. We should consider common nephropathic drugs, especially proton pump inhibitors and NSAIDs, and we should change them if possible. The VEGF inhibitors cause worsen hypertension and increase proteinuria more commonly, and TMA rarely. Early detection and frequent monitoring are the mantra for prevention of treatment, for prevention of these complications, and management is predominantly by discontinuation of these agents and use of immunosuppressive agents. Thank you.
Thank you, Professor Mahajan, for very nicely and elaborately discussing the role of checkpoint inhibitors and VEGF during health, its inhibition with the modern chemotherapy, targeted therapy, what is the mechanism of renal injury, the risk factors, prevention of renal injury and treatment. I think it was so well highlighted. And if we have any questions from the audience, they are welcome. And one thing I want to ask you, Dr. Mahajan, that as you have mentioned that acute tubulointerstitial nephritis, it manifests quite late, maybe few weeks, and in some of the meta-analysis, average duration has been mentioned around 90 days. So then why it is called ATIN, and is it that the effects come late with these inhibitory agents?
So that's very interesting for us as a nephrologist. As I said, one of the main mechanisms of acute tubular interstitial nephritis actually is the non-inhibition of regulatory T cells, which had been suppressing autoantibody formation to various other drugs, especially the proton pump inhibitors. Proton pump inhibitors the patient would have been using for so long that they would have some cells which would have been exposed to proton pump inhibitors, but these cells are normally kept under check by regulatory T cells. However, once we use immune checkpoint inhibitors, for one reason or the other, the regulation on these reactive T cells is released, and then they can lead on to acute tubular interstitial nephritis. So though the exposure of the drug had been in some period of time, but because of the inhibition of immune checkpoints, we have activation of these cells much later, leading on to tubular interstitial nephritis. So therefore, invariably, all analysis, all studies have shown that proton pump inhibitor use, especially the continued use, is a very important risk factor for immune checkpoint inhibitors associated nephrotoxicity. So my belief is that these drugs don't directly cause acute tubular interstitial nephritis, but more commonly cause ATIN because of other neoantigens or other release of other drugs induced acute tubular interstitial nephritis. So therefore, they don't correlate with the classic time frame of ATIN.
Dr. Mahajan, there is a question from Dr. Pallav Gupta, that how will you decide if malignancy has caused the glomerular disease or the side effects of immune checkpoint inhibitor? And second question to Professor Shyam Agarwal, that is it uncommon for malignancies to cause proteinuria if it was not present at the time of diagnosis of metastatic disease? So, Dr. Mahajan, you will answer the first question, and second by Dr. Shyam Agarwal.
Okay, well, it's a difficult call to take because we know that various hematological malignancies do cause MCDs and FSGS, and membranous we all know is associated with quite a common associated with other malignancies. So the most important way to differentiate is not pathologically, but actually clinically. You can see the onset of the disease, especially with the time frame of use of immune checkpoint inhibitors or anti-VEGF, and they can tell you that whether this is more likely to be associated with the malignancy or because of the drug. And the other would be discontinuation of the drug. So discontinuation of the drug actually improves proteinuria in majority, while this won't happen with malignancy. So I think so the history previously and the course subsequent to drug removal would be two most important ways to differentiate between these very common associations which can happen. And pathologically, a pathologist won't be able to guide you much.
So, is there any other question? I think if none, we close this session, and I would thank Professor Shyam Agarwal and Professor Sandeep Mahajan for really enlightening us on these subjects, which we in general practice we do not see, or we just leave it for the experts to take care. Thank you so much. Thank you, all the panelists. Thank you.
Thank you, chairpersons, and thank you, eminent speakers, for giving us a wonderful session, which was the first session of the day. We now move on to the next session, which is session number 6, and this will address updates in onconephrology. And for this, it's with great pleasure I would like to invite the chairpersons who will carry forward the proceedings. Our chairpersons are Professor Edwin Fernando. He needs no introduction. He is a very well-known nephrologist. He's the head of Department of Nephrology, an astute academician. He is from Stanley Medical College, Chennai. And our second chairperson is Dr. Dinesh Purani, who's the director, Department of Hemato-Oncology and Bone Marrow Transplantation at the Rajiv Gandhi Cancer Institute. Welcome, both of you, sir. May I also request now Dr. Edwin Fernando to kindly introduce our speaker, Dr. Narayan Prasad, sir.
Good morning, all. Thank you, Vedant, and thank you, the entire ONCONEPHRO update team from Gangaram Hospital. It's my pleasure today to introduce Dr. Narayan Prasad, who is the head of the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Dr. Narayan Prasad is the dynamic secretary of the Indian Society of Nephrology. He's had a brilliant academic career. He's been widely read, widely published, and widely traveled and lectured, and an extremely good friend of mine. Dr. Narayan Prasad will be addressing the issue of CAR cell therapy in renal cell carcinoma. Dr. Narayan Prasad, the floor is yours.
Is my slide visible?
Yes.
At the outset, I would like to thank team of Sir Gangaram Hospital, Dr. Vinant Bhargava, for this opportunity to speak before you. And I would like to thank our good friend, Dr. Edwin Fernando, for this kind introduction. as we all understand, we nephrologists are least exposed to this kind of therapy. And yesterday's presentation by Dr. Rajiv, by Dr. Priya Deshpande, today's presentation by Dr. Sandeep Mahajan, all have focused the same thing, that most of the time nephrologists are called upon when you have the complications. And here is the more of one of the important topics here that is thought to be the fourth generations of the chemotherapy. We have the card. So this will be my outline of the presentation. Just for introducing the card, how it came into the picture. He was Wayne Marasco. He was a father of the 5 young daughters, and he developed renal cell carcinoma. And in about 2000, he has got written the first grant for the card approximately 18 years before, and then he was the man who worked on this therapy, and now this is the fashions, and there are many literatures every other months are coming regarding the card. So coming to the basics of this renal cell carcinoma, we by this time, since yesterday and today's meeting, we all understand that clear cell renal cell carcinoma accounts for most of this carcinoma, 70 to 80%. This is the most common, most aggressive, highest rate of local invasion, metastasis, and mortality. What is more concerned here, 30% of the patients, 30% of the patient would have metastasis at the time of the diagnosis, and 30% plus metastasis after the local treatment. And why am I talking about that? You can see here up to the stage 1, 2, and 3, the best line of treatment is surgery, nephrectomy. And in stage 4, whenever you have, whether this is a local or distant metastasis, metastatic renal cell carcinoma, you have to go for the special kind of the treatment, like that has been highlighted by Dr. Syam Agrawal today morning, Dr. Sandeep Mahajan, like the PD-1 inhibitor or TKI, tyrosine kinase inhibitors, that kind of the therapy, and this card therapy comes into the picture. So when you look at why chemotherapy is not used in metastatic renal cell carcinoma, today morning, Dr. Syam Agrawal sir has highlighted that these are the radio resistant, and these are the tumors who are chemo resistant also. So only the role comes when you have the role of the surgeons are off, then medical oncologist comes into the picture, and then only with the metastatic renal cell carcinoma. So you have 4 generations of the chemotherapy you can divide. First generation was simply used about a decade before, direct cytokine therapy, lot of side effects, not used now. Second generation was TKI, VEGF inhibitors. Again, it was looking the safe. And third generation was immune check inhibitors that we have talked about. We have listened to Dr. Syam Agrawal sir in the morning about these immune checkpoint inhibitors, about the side effects from Dr. Sandeep Mahajan. And really, this is the 4th generation, which is called the CAR cell therapy. When you are exhausted with all existing medicines, then you can try for this CAR therapy. So we'll come out how these T cells and cancer are associated with each other. So this is the basics of the T cells in the cancer therapy. Whenever you have the cancer, some of the cancer cell antigens are expressed, then that is taken by the dendritic cell or antigen presenting cells, that is presented to the MSC, primary activations of, through the MSC it is presented to the T cells, and then trafficking of the T cells to the tumor cells. These T cells travels to the tumor cells, infiltrate into the tumor cells, and then recognize cancer cells by T cells, and finally these T cells kills the cancer cells. So this is all how this innate immune system of the T cells protect us against the cancer cells. Now, what is this chimeric antigen receptor T cells? Chimeric antigen receptor T cells, that is popularly known as CARD, are the T cells that are genetically engineered to express antigen-specific non-MSC. We all understand for presenting this any antigen to the T cells, we required MSC. MSC first binds and then, but it becomes non-MSC restricted receptors on their membrane. So that is the major difference. But what is more important that this CAR cell therapy, particularly in the renal cell carcinoma, actually when we look at the literature, most of the literatures are limited to hematological malignancy. And that too, in US FDA in 2017, approved this drug for the childhood refractory acute lymphoblastic leukemia. So not too much of the literatures on the renal cell carcinoma, but there are definite literatures on hematological malignancy. So how, just for the basic understanding, how this is prepared, CAR cells, chimeric T cells are prepared, that is prepared in the laboratory. So from the same patients in whom you see the tumors, you can get blood cells of white blood cells of the patient, then that is sent to the lab, which are our biomedical engineering lab, where these cells are activated, and then through the viral vectors, some of these receptors appeared on these CAR cells. So this is called the chimeric antigen receptor T cells. Here you can see there are some receptors appeared on the T cells, and these might have some hinge regions like spacers, transmembrane domains, and then co-stimulatory domains, and this the intracellular domain that is important for the signaling. And then it is expanded by cultures in the labs, and you can get the desired amount of these CAR cells, and then again it is reinfused in the same persons, and that is targeted against some of the cells like B cells having the expression of the CD19, and that CAR cells will kill this. But we have to understand that you are taking this from the same persons who have the cancers, and median manufacturing time is about approximately 2 to 4 weeks. So what happens, whether when you have so much of the invasive cancer, it takes times in manufacturing from the same persons. So that is the one of the limitations. So just to recapitulate what happens, we take the bloods from the patient, T cells are extracted from the samples. It is easy to do, it is not that difficult. Then it is sent to the engineering labs, biomedical engineering labs, to where it has been converted into the CAR. And these CAR cells, where there is expression of the chimeric antigen receptors. And these CAR cells are again expanded, grown in cultures. When you have the desired volume of the CAR, it is reinfused into the patients. And then suppose wherever this tumor is there, whether this is in the kidney or at any part, whether it is in the lung, this will go attack to the cancer cells and will kill these cancer cells. So this is as I have shown you, most of these CAR cells are approved for hematological malignancy, particularly diffuse large cell B-cell lymphoma. Here we can see FDA has approved this CAR cells for this therapy. So what are the challenges facing the use of the CAR T cells in treating solid tumors? Now the questions come to why this is not used. Still, there are a lot of things which happens within the body with the tumor cells used to do. Some of the tumor cells membrane does not express a specific target. Suppose you have made anti-CD20, but there is no expression on the tumor cells. Poor intra or peritubular trafficking. Trafficking particularly becomes important in the solid tumors. You have limited CAR persistence. When you have given the microenvironment of the tumor is such that it will not allow the CAR to persist there for longer period of the time. Then CAR cells are destroyed by hostile tumor microenvironment and absence of our cancer-specific antigen in several tumor types that is suitable for inclusion in the CAR structures. So one of the important challenges is there in the solid tumors. it is easy in a hematological malignancy because direct infusion is given into the blood. There we can see that can work. But here what happens when you can see when you infuse the card or the solid tumors to travel it to the kidney, there is some trafficking. So you have to cross this blood barriers, and then through this endothelial cells you have to escape and you have to reach to the tumor cells. And then across the tumor cells there are many tumor microenvironment that do not allow it to attack, because sometimes there is shortage of the tumor specific antigens. You have the microenvironment like tumor associated macrophages there, T regulatory cells, and myeloid depressor cells are there. So what they do, they secrete interleukin 10, TGF beta kind of thing and suppress the activity of the T cells. So what happens? They do not allow the T cells to attack on the tumors. This is the microenvironment. So you have to take care of the microenvironment around the tumor cells also. And you have to take care of these T regulatory cells, tumor associated macrophages, MDS cells. So that all should be taken care, and then only these T cells becomes eligible or becomes effective to kill the cancer cells. So in the solid tumors, you have a lot of problems. Unlike hematological malignancy, CAR T cells tracking and infiltration, CAR T cells resistance to the tumor microenvironment, and multi-targeting CAR T cells. So what we can do, we have to just for understanding this in a better way, what we can see here. What are the different challenges or innovative approach to make such a CAR cells which can be effective against any cancer cells? So there is a one CAR cells which is called inverted chimeric receptors. So what they do, they just convert the inhibitory cytokines into stimulatory signals. Other important is the CCL ligand. This is the ligand through which your CAR cell enters into the cells. It helps in trafficking. So you have the engineered expression of the cognate chemokine receptor, CCRs, fibroblast activated proteins, and heparinase that takes care of the tumor microenvironment and allow these CAR cells to enter into the tumor cells. Then you have just listen to Dr. Mahajan, that immune checkpoint. That is the mechanism. So at the same time, when the tumor has the expression of the high expression of the PD-1 or CTLA4, you can chimeric cells can be made along with these immune checkpoint inhibitors. So here you can see the mesenchymal stem cells that again express a lot of the inflammatory cytokines to activate this T cells, and the survival of the T cells are improved with this mesenchymal stem cells. So that can be modified. There are several things which can modify from in the tumor microenvironment. So engineering transcription factors to oxidative stress, immunosuppressive metabolites, antibody against the inhibitory cytokines, and antibody against the angiogenesis, like anti-VEGF antibody. So that kind of things can be produced, and that allows these CAR cells to enter into the solid tumors and take action against these cancer cells. So here we can see for the examples what happens, how the tumor cells change their position and their receptors. Here we can see receptor genetic mutations can happen, and tumor cells might not have any antigen receptors. There we can see the tumor cells can totally change their cell lineage and prevent from recognitions from this T cells. You might have the epitope maskings. So tumor cells also try to protect themselves in different ways. So the current thinking is to have this multi-targeted CAR approach. What you can do, we have, if you have the CAR cells against CD19, so you can have the CAR cells against CD20 also. That can be given simultaneously or that can be given sequentially. You can have the one CAR cells having the two receptors, CD19 and CD20 both. So this is called bicistronic. There is a co-transductions. Co-transduction encodes two CAR constructs via transductions with multiple vectors. You can have the multiple vectors, three different kind of the CAR cells and acting on the three different receptors. And one can be the tandem, where the single CAR cells can have the multiple receptors and that can attack on the cancer cells. So these are the different multi-targeted CAR approaches are there in the practice now, and the people are trying to develop this. One of the important CAR which is called the TRUX, T cell redirected for universal cytokine killings. This is called the fourth CAR generation, also known as TRUX. Here you can see one CAR cell, one T cells have multiple things, immune stimulatory molecules, multi-antigen targeting combinations, knock-in genes, knock-out genes, control and inducible system. So you can have on the same cells different kind of receptors that can go identify the cells, cancer cells, and can kill the cancer cells. And now, what to do about the persistence of this CAR T cells? That the scientists are also working on that part. A strategy mainly include Boolean logic gates, which comprise AND or NOT gates. AND gates gets activated only in presence of both predetermined antigens are there. OR gate requires either one of the two predefined antigens. If antigens are there expressed on the cancer cells, when they need to be activated. NOT gate help identify normal cells through deactivation if a specific antigen is detected. So that prevents from the cytotoxicity of the normal cells. So that kind of the CAR cells for the persistence on the tumors are also engineered. So coming to our topics of the potential application of this CAR in renal cell tumors, there are only few literatures are there in concern to renal cell carcinoma, particularly metastatic renal cell carcinoma. Autologous T cells genetically modified to express CAR against carboxy anhydrase 9, so popularly known as the CACs, were administered to 12 patients. In this study, they have administered in 12 patients with the metastatic carcinoma. What they have seen, they have treated the 3 cohorts with a maximum of 10 infusions. What was the important concern in the early part in 3 different cohorts? They have shown that the liver enzyme toxicity was there. Even at the lowest CAR cell dosage, 4 out of the 8 patients have shown this liver enzyme toxicity, liver toxicity was there. And when they have done the biopsy of this bile duct, they have shown there was infiltration of the T cells, including the CAR cells there. So now the pupils are trying to overcome this toxicity of tumor toxicity, on target, but of tumor toxicity, how we can take care of. So they have pre-treated with the CACs monoclonal antibody in their 4th cohort, and they shown that there was no liver toxicity. So on target toxicity is antigen directed. It is so in patient proof concept, they shown that on target toxicity is antigen directed, and it can be prevented by blocking antigenic sites in off tumor organs, allowing higher T cell dosage. So that kind of things can be done. Coming to the one basic science study which has shown again, when we are using this CRACs CAR9 with sunitinib. Sunitinib modulates anti-tumor immune response by improving T cell infiltration and functions that we all understand. The second generation CAR targeting human renal cell carcinoma, a specific antigen carbonic anhydrase, which are usually highly expressed in the renal cell carcinoma. Cytokine releasing and cell killing assays showed that the CRACs CAR T cells have a specific effector function against CRACs and renal cell carcinoma in vitro. So this was in vitro study and proof, and they have shown that sunitinib and both can be used in combination and can have the synergistic effect. This was studied in the mouse model. You can have T cell activation upon exposure to patient-derived tumor tissue, a functional assay to detect, or adoptive T cell therapy. Primary human T cells expressing CRACs CAR were able to respond to CRACs positive, but not CRACs negative. Beforehand, you can have the idea with this immunohistochemistry of the cancer cells, that whether this is the cracks positive or cracks negative. If this is the cracks positive, then use this kind of the card. If cracks negative, not to use this kind of the card. That is something called the precision medicine. At present, that is required. I will talk a little bit later on this. Other important combination that this was the radio resistant. Whether the combination of the card with the radiotherapy in renal cell carcinoma can be done. Just now, half an hour before, Dr. Syam Agrawal sir was talking, and Dr. Purohit was also talking about the radiotherapy. There is definitely an upcoming role of the radiotherapy there. Despite this is a radio-resistant tumor, what this do? They enhance the CAR-T efficacy by increasing the tumor antigen expression on cancer cells and stimulating interferon gamma secretions. So when these are expressed on the tumor cells, then the activity of the CAR against these cancer cells are improved. So it is possible that if the cancer is too much bulky, giving the radiotherapy and followed by the CAR may one more approach for this difficult renal cell carcinoma, particularly metastatic renal cell carcinoma. Improving CAR cell therapy of solid tumor with oncolytic virus-driven production of biospecific T-cell engager. Here you can see combining anti-FR CAR cells with an oncolytic adenovirus expressing BiTE-targeting EGFR. A combined action of the virus, BiTE and CAR cells leads to synergistic control of the tumor growth and increase overall survival without compromising the safety. So that kind of the precision can be achieved. The most important things coming forward, the nephrology perspective. Nephrologist perspectives is what the nephrotoxicity associated with the CAR cell therapy and what we should know. Coming here, one of the important things by this time, managing so many COVID patients, we all must be knowing about the cytokine release syndrome. And we understand that whenever you are giving the T cells, that will release a lot of the cytokines and will have the cytokine release syndrome. Aware about diagnostic criteria of cytokine release syndrome, fever for at least 3 days, CRP of more than 20, or at least one clinical signs of the toxicity like hypoxia, hypotension, and neurologic changes there. So what is of importance for us? Cytokine release syndrome, IL-6 is predominantly secreted, that is inflammatory cytokines. Inflammation, increased permeability of these capillaries leads to the third spacing, hypotension and hypoperfusion, and approximately 25% of patients may have the cardiac damage and might have the cardiomyopathy, hypotension, and organ dysfunction, as rightly pointed out by Dr. Mahajan also and Dr. Ashwini Gupta also said. It may happen many times after 10 or 15 days after this, all these insults happen. So this should always be in our mind. Initially might be the only perirenal, later on they established acute tubular interstitial nephritis or acute tubular necrosis kind of things we can see. So that should be in the mind of our residents, nephrology colleagues, because whenever we have got the call from this onconephrologist, then oncologist, medical oncologist particularly, we should have all these things in the mind. Other important things can have this hemophagocytic lymphocytosis, macrophage activation syndrome, and that is associated with high levels of IL-6 and IL-10 and can be associated with acute kidney injury. There are certain criteria, but important, the persisting fever, some splenomegaly, cytopenias, but two important clinical parameters whenever you should have the suspicion: increased triglyceride levels and hyperferritinemia. Ferritin level is, if particularly very high, we should suspect that probably there is a macrophage activation syndrome, and that needs to be taken care immediately with some of the steroids, some of the anti-inflammatory agents, so that this can be checked in. Otherwise, this may lead to severe injury. Tumor lysis syndrome, that we all understand, but tumor lysis syndrome, Professor now know that use of the allopurinols may abate some of the tumor lysis syndromes, and we should always keep in the mind this kind of this therapy can lead to tumor lysis syndrome, and that is associated with this acute kidney injury that we all nephrologists know now. Electrolyte disorders, that is hypokalemia, hypophosphatemia, and hyponatremia can be seen. CAR cell therapy directly or as a result of the cytokine release syndrome can cause this. Exact mechanism is cannot be pinpointed, but these are the common observations that has been revealed in this study published in the Nature in 2018. AKI and electrolyte abnormalities that we can see after the CAR therapy. This was the case series all collected for the 2 years. 78 hospitalized patients in 2 cancer centers. What you can see here, acute kidney injury in 19%, cytokine release syndrome can be observed in 85% of the patients, hyponatremia 75%, hypokalemia and hypophosphatemia can be seen in approximately half of the patients. So these are the concern for the nephrologists. So on target and off tumor toxicity, CART and non-renal adverse effect that we should also keep in the mind, particularly the neurological complications. These patients after this cytokine release syndromes can have the seizure, confusion, myoclonus. So what is important, how to prevent this, get this better target effect and off tumor toxicity? There is a requirement in the change of the expression of the different receptors on the CAR so that they can be specifically targeted against that particular antigen and can cause less toxicity. Of tumor toxicity should be less. So principle of toxicity management that we should know about the cytokine release syndrome. We all understand during the COVID time, there are a lot of cytokine release syndrome we have encountered during our ICUs, taking care of the COVID. And there tocilizumab has been used because this has a very good anti-IL-6 effect, along with this high dose of the steroids. But still this is controversial in cytokine release syndrome. Not here, but in COVID, I do not know about the exact situation, what is the position of the tocilizumab. But still it in the practice, if IL-6 level is very high, tocilizumab and high dose of the steroid can be used. If neurotoxicity is high dose of the steroids, and then both cytokine release syndrome and neurotoxicity are with tocilizumab and high dose of the steroids can be used. So now coming to the precision medicine, that is the why I was trying to highlight that heat map genes. Now you have the NGS in your hand, and there in this study, what they have shown, they have got the heat map genes. Some of the genes were upregulated, some of the genes were downregulated. You can find out these genes for the angiogenesis. You can find out the genes for the immune system and myeloid inflammation associated genes. This is the last slide.
Yeah. Thank you, Naren.
So
yeah, please complete.
now this precision medicine is there. If you have this angiogenesis, then subgroup expressing higher T effector gene signature responded best to immunotherapy. If you have high angiogenetic signature, TKI might be the choice. If you have this high myeloid gene signature, these patients do not respond better to immunotherapy, had usually poor survival. There are several clinical trials going on for this, none of these odd for the renal cell carcinoma. And in conclusion, we can say for treatment of renal cell carcinoma, it is in infancy, and in childhood, you can say on target and off tumor toxicity is concerned. Cytokine release syndrome, multi-organ failure should be kept in mind. AKI may be induced after CAR. Electrolyte disturbances that should be in the mind, and above all, precision medicine is the future. So we should always get the heat map genes by NGS, try to see what are the genes expressed on the tumor cells, and you can choose the therapy available as per the precisions, as per this antigen expressed on the tumor cells. Thank you, ladies and gentlemen. And other important thing is that such kind of the CAR cell therapy may be future application in many of the glomerular disease and many of the transplant patients also who are refractory to treat. So that is the future for the nephrologists. Thank you, ladies and gentlemen.
Thank you, Narayan. That was an extensive talk on a new subject. We know that onconephrology is becoming a separate subspecialty of nephrology. And this is a very new modality of therapy, and we have to, as nephrologists, we have to be aware of these side effects, because more and more, as oncology is also advancing very fast and these therapies are available in our country, and we get a lot of referrals from these specialists to us, it's mandatory that we know more about this. Thank you for a very extensive talk. So we take the questions now, Vinay, or later?
We are running a little late, sir. If there's
Okay,
any.
we shall take it at the end if we find time. So thank you, Narayan. Thank you for the talk. Over to Vinay.
Thank you very much, sir. May I request Dr. Dinesh Burani to kindly introduce.
Yeah, I'm Dr. Dinesh Burani from Rajiv Gandhi Cancer Institute. I have an opportunity to introduce my dear friend, Dr. Dharma Chaudhary. He is my contemporary senior director, bone marrow transplant and BL Kapoor Super Specialty Hospital, New Delhi. He's quite experienced hematology, the transplant physician. He's going to talk about the hematopoietic stem cell transplant and kidney. I think we badly need a nephrologist in our transplant. So I'll request Dharma to brief us.
Thank you, Dinesh, for your kind introduction. And I'll thank the ONCONEPHRO team of the Gangaram and Vinant for inviting me to deliver talk. And what I'm going to speak in over the next 15 to 20 minutes about what are the possible complications of that stem cell transplant in the perspective of kidney. And I'll just probably take the overview for this because it's an extensive the complication list, and the majority of time the kidney involvement, other than beside myeloma, it's secondary to the treatment what we deliver to the patient. So just to brief that what the stem cell transplant involve, it's basically a conditioning chemotherapy to be given to the patient, and thereafter the donor hematopoietic stem cell infusion, which are collected from the patient for auto transplant and the allo transplant from the donor. And all the allo transplant, the patient receive post-graft immunosuppression to control the graft versus host disease and to stabilize graft host tolerance. And these are the timelines. So the one is wiser, what complication you expect at the particular time frame of the transplant course. When you give the ablative chemotherapy, the patients will be getting high dose chemotherapy, radiotherapy, or immunotherapy. So complication is due to the drugs. Once they complete the chemotherapy and then due for stem cell infusion, so many times the incompatible graft or the cryopreserved DMSO can lead to toxicity. And in neutropenic phase, till they engraft almost 2 to 3 weeks, there will be mucositis, there will be the chances of veno-occlusive disease, and the sepsis and sepsis related complication. Once they engraft, these patients are usually immunodeficient for up from 3 months to 1 year, and where the complete immune reconstitution happen. So these patients are at risk for viral infection and other encapsulated bacterial infection. At the same time, after engraftment, there is risk for graft versus host disease, both acute and chronic, and all the complications we see related to the kidney are either the manifestation of the complication or the treatment related complication. So these are the regime related toxicity we see during the initial phase, pancytopenia, then RRT, regime related toxicity, particularly veno-occlusive disease or sinusoidal obstruction syndrome, mucositis, graft versus host disease, and sepsis related complication with the bacterial, viral, or fungal. So the renal dysfunction is quite a common complication of HSCT and major cause of morbidity and mortality. And we call it chronic kidney disease in the transplant patients. It usually refer to manifestation of renal disease that occur after day 100 and acute cover-ups up to day 100. And these are the list of the common renal complications, and the foremost is the sepsis related. Then the drug toxicity, both either chemotherapeutic agent, calcium inhibitor, or nephrotoxic antimicrobial, antibiotics, antifungal, and antiviral. Thrombotic thrombocytopenic purpura is a really challenging complication, and the veno-occlusive disease or sinusoidal obstruction syndrome. We do transplant most of the time in the remission status, but sometimes the refractory patient, those who are sensitive to high dose chemotherapy, can lead to tumor lysis syndrome. And one of the rare complications we do see, but it's really problematic, it's a chronic glomerulonephritis related to kidney graft-versus-host disease. So when we decide about the transplant, all the transplant physicians look at who are that risk patient. So this is the tool which identify what are the chances of any transplant morbidity and mortality, what we call hematopoietic cell transplant comorbidity index or SORO index, and all the organ system they get scoring. And if you look at the renal, those who have baseline creatinine of more than 2, who are already on dialysis or prior renal transplant, are at risk from renal point of view. So when this is the review article, the pre-transplant predictor and post-transplant sequelae of AKI after allotransplant, and what they found that the patient, those who have SCT-CI score of higher, 0, 1 to 2, or more than 3, the chances of the AKI in the first 100 days is 21% to go to up to 80%. So this is important to assess the SCT-CI to predict the incidence of AKI, which is a strong indicator of worse prognosis after stem cell transplant. So AKI defined as doubling of baseline serum creatinine within the first 60 to 100 days after HSCT, and then incidence of acute kidney injury varies from as low as 6.5% in auto transplant setting and to go up to 80% in patient who goes to ICU for one or more complication. In allotransplant, typically we see almost 50 to 70, 80% of patients will get some kidney injury during the treatment course. And this is the published literature, so the various published large series. What they say that the incidence of the AKI ranging from 30% to the 80%, and the various causes has been postulated. And when you define the AKI, this classification, there are according to the serum creatinine level. So they say rifle or Akin or grading. So rifle is risk injury, failure, and loss and state kidney disease. Akin is staging and grading according to the GFR. And these are the predominant mechanism, either pre-renal, renal, intra-renal, or post-renal causes or mechanism lead to the AKI. I will not go into the detail of the each and everything. Probably will cover later. Sepsis is probably, if you say 50% of patients will have some of the AKI related to the severe sepsis or septic shock. So vasodilation and reduced renal blood flow resulting in ischemia and direct renal tubular insult by inflammatory cytokine. When you treat sepsis, and now the currently growing the gram-negative sepsis, the resistant E. coli requiring cholesterol. So nephrotoxic antibiotics for sepsis and hypertension all have synergistic effect resulting in AKI. Nephrotoxic medication earlier used amphotericin B, very common because all heme malignancies, they either have pre-existing fungal infection when you're treating aplastic anemia or refractory leukemia. So amphotericin was the gold standard earlier, but now new antifungal which led to the less renal toxicity, and amphotericin used to cause this renal toxicity by vasoconstriction of renal vasculature, leading to hypoperfusion and renal tubular damage. So we only use these days amphotericin only in the selected patient. And this is the article published by Fred H. Group. So they identify acute renal failure, hematopoietic incident risk factor, and what they found. So contemporary to believe that liposomal amphotericin B is safe, but there is a risk associated with either liposomal or conventional amphotericin B, and this risk to AKI increase if there is associated VOD and other complications. So one should use amphotericin B wisely in the current setting when you have more safer azoles and the echinocandins. All the transplant patients, they do get acyclovir and cyclosporine. And acyclosporine can cause formation of crystalline renal tubule and collecting duct, resulting in obstructive damage, and especially with the IV administration of high dose. So the patient who are getting high dose of acyclovir, particularly in the setting when they have mucositis, they cannot take oral, they lead to the crystal formation. And cyclosporine which is a backbone for almost the 70 to 80% center currently still in the world. It can lead to the renal vasoconstriction or thrombotic microangiopathy and lead to the AKI. And the crystal you typically see in the urine of patients who have got high dose acyclovir and developed crystalluria and acute kidney injury. CNI nephrotoxicity is quite common, and all the GVHD prophylaxis regime or the treatment for GVHD is the primarily with the cyclosporin A or tacrolimus, which act as a the blocking the T cell proliferation, and this can lead to the renal toxicity, and this can cause both acute CNI nephropathy toxicity and chronic nephrotoxicity, and can involve both glomerulus as well as tubular. And I'll just tell later. So acute CNI nephrotoxicity, the vascular effect is due to acute arteriolopathy, and there's increase in vasoconstriction and reduction in the vasodilator mechanism, increased sympathetic activity that can lead to the acute glomerular damage. The tubular effect is due to toxic tubulopathy. There's isometric tubular necrolization. This is one of the real challenging complications of the allotransplant, the sinusoidal obstruction syndrome, and it can cause kidney injury, particularly when this is severe, like hepatorenal syndrome. So the conditioning regime, cytokine injured from the injured tissue, use of calcineurin inhibitor, and microbial product and graftment, they all lead to the endothelial injury, and they activate endothelial. And this causes the increase in the denuded endothelial, lead to the procoagulant status, this pro-inflammatory status, and the vasoconstriction. They further lead to the capillary leak and further endothelial, the damage, detachment, centrilobular venous obstruction, and particularly ultimately hepatic damage. So this occurs usually in first 21 days of the transplant and has been diagnosed with it is defined criteria, and in the children they are a little modified. But the VOD is a diagnosis of high index of suspicion. Whenever the bilirubin is going high, more than 2, there is hepatomegaly or right upper quadrant pain or weight gain. All the allotransplant or even autotransplant, all the hematologists are very finicky about gaining weight, fluid retention. These are early sign of veno-occlusive disease. So anywhere the more than 5% of weight gain should consider this entity and control the weight with the restriction of fluid, diuretics, and involving nephrologists before even this major complication happen. And when comes the kidney involvement in this VOD, so if you look at any more than mild the VOD, which can go unnoticed, but moderate to very severe, the kidney is involved, the creatinine goes more than 1.2 to in the very severe more than 2. So wherever the kidney is getting involved, early in the involvement of the nephrologist, early dialysis, many times the nephrologist will say, okay, wait, the urine output is okay, but these patients go into cascade, and this becomes an irreversible situation. One can identify this sinusoidal obstruction syndrome or SOS by circulating endothelial cell if they are more than 100, or the biomarker, the tissue plasmin activated inhibitor 1 can predict the severity of SOS. How to treat or prevent? The prevention is the only key. So you have to be very wise in this time, control the weight, look at diuretics, and early use of defibrotide, because if you are suspecting VOD, you treat with defibrotide, and that can reverse. The complication of the transplant where the renal matters, the DMSO toxicity. And DMSO, what we do, all the autologous stem cell transplant, which are cryopreserved, or sometimes allotransplant also, because of the various region, is cryopreserved. So if this is cryoprotectant to the cell, and when you thaw, there is hemolysis of the cell, and which liberate heme protein and block the distal tubule and cause tubular obstruction, and sometimes can lead to the renal failure. And sometimes DMSO per se is also the toxic to the kidney. So the management mainstay is alkalinization of the urine, or you use mannitol forced diuresis for these patients. The specific infection which is pertinent to the stem cell transplant and AKI, and these two virus infection, BK virus and adenovirus. Adenovirus typically cause tubular intestinal nephritis and cystitis, and one should use IV cidofovir, now it's available in India, or intravesical cidofovir. And BK virus is a cause for the hemorrhagic cystitis. We see often there's the immunosuppression reactivate dormant virus in the urinary tract, causing renal tubular injury and hemorrhagic cystitis. And the main treatment is supportive care. Nothing else you can do. If there's early hemorrhagic cystitis, you have to continue your immunosuppression, because otherwise your graft versus host disease will kill. So you have to balance out the immunosuppression, what is you need, and supportive care for maintaining BK virus. And sometimes the BK virus we treat with the cidofovir as well. A tumor lysis syndrome, my previous speaker spoke about when you're using CAR T cell, you can have tumor lysis. In the transplant also, those who have the patient in the partial remission or refractory disease, one can get the tumor lysis syndrome with the intensive conditioning chemotherapy. And this is biochemical syndrome. It's better to predict early and treat. Some of the patients may require dialysis even, particularly those who are high grade, the lymphoid malignancy like bucket lymphoma. A very interesting observation by Kaliskin, the hypoalbuminemia and AKI. So hypoalbuminemia has a most significant relation with the development of AKI in transplant recipient. And how does it act? This low baseline serum albumin correlate with the development of AKI? And possible explanation, the author given is the decreased oncotic pressure due to hypoalbuminemia result in intravascular volume contraction and renal ischemia. So baseline serum albumin level prior to HSCT is an important risk factor for development of AKI. So people are looking at novel marker for AKI in HSCT, and these three marker has been studied and now being practiced as research tool. The elafine, urinary liver trans type fatty acid binding protein, and urinary alpha-1M biomarker for severe AKI after HSCT. So what is the management of AKI? So the first and foremost, as Dinesh rightly said, the involvement of nephrologist at the early stage can help in the prevention of AKI and related complication. Second is that you should use your treatment, the protocol or conditioning regime according to SCTCI. So use reduced intensity conditioning tox regime wherever possible. Close monitoring of nephrotoxic medication, particularly amphotericin and colistin. Use of alternative antifungal, particularly azoles. Early identification and management of sepsis and the diuresis. So coming to the CKD after transplant, CKD developed in almost around 15 to 60% of the recipient, is presenting a slowly increasing critical level in setting up progressive hypertension and anemia, and kidney biopsy is extremely useful tool for diagnosis. These are the great staging according to GFR, and what commonly we see: chronic graft versus host disease associated glomerulonephritis, chronic CNI nephrotoxicity, and SCT associated TMA. So these three entities we see routinely, and chronic glomerulonephritis does happen. The chronic GVHD, you do tissue biopsy, and they present as nephrotic syndrome with or without renal insufficiency, proteinuria, edema, and hypoalbuminemia, more commonly with the reduced toxicity transplant, and the T cell mediated mechanism or B cell contribute to GVHD through antibody mediated mechanism. And the histology, mainly we see the membranous glomerulonephritis, membranoproliferative glomerulonephritis, and MCD. And what the literature review, the case series published for 42 patients over the period of 20 years, and they reported this is the spectrum. Every possible disease that has been covered can lead to the this entity, chronic glomerulonephritis, the GVHD of the liver. So what happens? The MGN has a poor outcome because complete remission rate is only 27% versus 90% in the MCD, and the response to treatment and rituximab is the key. So treatment is with the high dose prednisolone without reinstatement CNI. Rituximab is the key for managing nephrotic syndrome secondary to the chronic graft versus host disease. TMA is really a problem after transplant. The endothelial injury secondary to vasoconstriction associated ischemia, as we suggested, that cyclosporin tacrolimus can add further, increase platelet aggregation and activate prothrombotic factor. The CNI, chronic CNI nephrotoxicity could be because of vascular, the effect, the hyaline deposition and arterial hyalinosis, which is irreversible, tubular interstitial effect. So the
Dharma, can we just
I'll just quickly pick up.
Sure.
So global effect and the CNI nephrotoxicity chronic can lead to the electrolyte disbalance, and how to identify the risk that some patients are genetically predisposed, but the systemic overexposure to cyclosporine and tacrolimus, or local overexposure, or use of NSAID along with this. So cyclosporine is metabolic. One has to remember the CY3A5, the polymorphism, which can predispose to these cyclosporine toxicity. So management is TDM has to be carefully monitored, avoid other drugs, and use of immunosuppressive medication other than CNI. And adjunctive therapy can be used for managing this complication. TMA after transplant is very disaster complication. Incidence range from 10 to 35%. Allo transplant go up to 76%. It is associated with the significant morbidity, high mortality. Early identification is key, and the pathophysiology, activation of endothelial cell, the procoagulant state, activation of APC, and activation of the complicant cascade, because that has a role in for therapeutic. So I will not go into detail, but one has to remember this, the alternate pathway complement, which makes the C5A, which lead to inflammation, chemotaxis, cell activation is key. And I'll probably quick up. So one has to use complement inhibitor wherever is required, prophylactic or in treatment. And risk factor for TMA are various, some are inherent, transplant associated, or post-transplant. So there's 3 hit. First hit is underlying predisposition, second hit is endothelial injury, second hit to conditioning chemotherapy, and third hit is complementary activation because of other drugs, GVHD, infection, antibodies. And these are the parameter one has to look at: LDH, cystocyte, creatinine, haptoglobin. And these are classically triad. One has to be very aware: hypertension, de novo thrombocytopenia, and elevated LDH. One should look at proteinuria, new-onset of anemia, and cystocytes. And one should look at the complement level, reticular count, and other biomarker. Prognosis is bad after 18 years, more worse in the mud transplant or haplo transplant, or where you have high cystocytes, and proteinuria is bad. So the treatment is remove the CNI, underlying disorder, treat disease. Plasma exchange is not benefit.
We have to quickly
just ending. So I would end here. The renal injury is very common. One has to involve the nephrologist before and identify the risk factor and modify the drugs. I'll end here and will be happy to take questions. Thank you, Dinesh.
Sorry, Dharma, I had to be rude to you, but because of the shortage of time, this is a whole day topic. Dharma is very. I'm feeling sorry for him. He has to cover it within, and he has nicely done the job, trying to cover it within 15 minutes. I don't think we have a time for the questions. I think we can do it later on. With this, I hand over to Vinit. Thank you.
Thank you very much, sir. Thank you, Dr. Dharma, and thank you, Professor Narayan Prasad. Thank you, chairpersons, for taking us through the session on updates. With this, we move on to the second last session for the day, which is on diagnostic dilemmas. So for this, I would like to invite our chairperson, Professor Sanjeev Saxena. Professor Sanjeev Saxena is a very well-known entity. He's an astute academician. He's a prolific clinician, and he's a chairman, Institute of Renal Sciences at the Pushpavati Singhania Hospital and Research Institute at New Delhi. The second chairperson is Professor Sudhir Chadda, who I very fondly call as Chadda sir. He's a senior consultant in the Department of Urology and a very dynamic urologist. And I would request the two chairpersons to kindly take us through the entire session. But first, I would request Dr. Sanjeev Saxena to give a brief introduction for our speaker, who's going to give us the nephrologist perspective of assessment of renal mass, Dr. Santosh Varghese. Now, this lecture is going to be a hybrid lecture. Dr. Santosh Varghese is presently traveling to Trivandrum, and so he has given us a pre-recorded video lecture. He is online, and he will be taking up questions at the end of the presentation. Over to you, sir, Dr. Sanjeev Saxena.
Thank you very much, Vinay, and thank you the entire Gangaram team for having me here. Assessment of renal mass is a rather tough way to go about. And I think in today's time when nephrologists and the urologists work together, well, the perspectives are not very different. Short of saying that, a surgeon may look at a mass as a surgical delight, but for the nephrologist, the fact of the matter is that the mass and the subsequent surgery may become a nephrologist nightmare. And therefore, there is some difference. Renal masses always are a challenge. Important is not just to see whether it is benign, pre-malignant or malignant, but also what is the renal mass left after the mass has been removed. And that would help our surgical colleagues to decide on what type of surgery to do surgery at all. And therefore, Dr. Santosh is the best person for this. He is the head of CMC Vellore, head of nephrology. And if you have heard him earlier, you will definitely enjoy his talk. It's scientific as well as very well delivered. Dr. Varghese, please.
At the outset, let me thank the organizers for inviting me to give this talk at this very important conference. The topic given to me is to speak about the assessment of a renal mass with the widespread use of ultrasonography and CT scans. There's an increased detection of incidental renal masses. Now we know that we have seen this time and again in our practice. Apart from this, renal cell carcinoma is also called an internist tumor, while only 10% present with flank pain, hematuria, or as a mass. A lot of patients do present with weight loss, fever, hypertension, hypercalcemia, and night sweats, and therefore the name. At autopsy findings in patients who are aged 50 years and above, there may be half of them having one or more renal cysts, and that's completely expected. Clinical studies show that the number may be a little lower. It's about 1/3 of patients. Most of them are benign, simple cysts requiring no further evaluation. Now, why do we bother about the incidental renal masses? The question before the clinician as well as the patient is, can this be malignant? Now, the risk actually is not too bad. In almost 6,000 consecutive patients aged between 50 and 80, what was found is about 0.2% of these are malignant. And the lifetime risk of RCC in a person who's 40 years old is only 1.34, and the risk of death from RCC is little more than 0.5%. Broadly, these renal masses are categorized into cysts, tumors, and inflammatory lesions. Cysts may be simple, complex, or multiple. Tumors may be masses, including we most encountered the renal cell carcinoma and others, and benign masses which are less common like adenoma and adenomyolipoma, etc. And inflammatory lesions, infection, infarction, and sometimes not classified strictly as inflammation is hematoma causing from a trauma. Simple cysts are usually asymptomatic, but we'll come to this in a few slides. They occasionally produce flank pain or abdominal pain, and they may be palpable per abdomen depending on the number and size, or they may have hematuria. Malignant masses have the same as above, or there may be paraneoplastic syndromes. I remember a patient who we saw as I was doing my medicine post-graduation who had severe peripheral neuropathy. And the patient actually had an RCC when we did the complete evaluation. Inflammatory lesions are usually not incidental, usually have clinical symptoms like fever, chills, or obvious UTI, and investigations will show infected cyst or an abscess. So a proper history and radiological imaging interpretation is required. Like was said earlier, majority of the cysts require just surveillance, but complex cysts and solid masses require further evaluation. A simple cyst is spherical ovoid in shape with no internal echoes and a thin, smooth wall separate from the surrounding parenchyma, and the posterior wall enhances, indicating wave transmission through the water-filled cyst. The most important thing is that the contents are clear, there are no internal echoes. The likelihood of malignancy in these patients is extremely small and they do not require any investigation. The ultrasound is usually enough. The sensitivity is about 80%, but there's an important caveat, that is, it does not identify masses that are less than 5 millimeter in diameter. So when there is inadequate visualization on ultrasound, or if there are calcifications seen on ultrasound, or if there are septae or multiple cysts which could be obscuring a potential malignancy, the investigation of choice is a contrast CT scan of the kidneys. And of course, symptomatic patients also require contrast CT scan testing. There is an evaluation called Hounsfield units, which is the relative density of the various substances, and water is 0, which is the standard. In 1986, Bosniak came up with a classification which I'm sure all of us have heard out. I'll go into a little bit more detail. It's a 4-part classification. This still is the one that we most commonly use and the best available so far. In addition to characterization of the cysts, it also uses Hounsfield units, and they categorize lesions in order of increasing probability of being malignant. So these are the Bosniak cysts: 1, 2, 2F, 3, and 4. Now the Bosniak 1 is, I'm sure, what we have most commonly encountered. It's almost universally benign. The walls are extremely thin. There are no septae, there are no calcifications, no solid components, and there's no contrast enhancement. The internal echoes are no greater than 20 Hounsfield units, where water is 0 with a range of -20 to +20. So up to 20 is permitted. 2 may contain thin septa, but these are also almost universally benign. They may have thin or slightly thickened calcification within the cyst wall, and the contents may be slightly more hyperdense, up to 90 Hounsfield units. But these are due to blood, protein, or colloid. There's minimal but unmeasurable enhancement. High attenuating cyst without enhancement, less than 3, is acceptable. 2F, the F here says that follow-up is needed. So it's more than 2 but less than 3. The number of septae are more, or there may be minimal smooth thickening of the wall or the septa. The wall or the septa may have calcification, but none of these areas have enhancement. High attenuation cysts more than 3 centimeters without enhancement also are 2F. If it's less than 3, they are 2. If it's more than 3, it is 2F requiring follow-up. 3 is indeterminate. There's thick nodular multiple septae or wall. There's measurable enhancement present. Half of these may be malignant, or in other case it is little less than half, 12 out of 29. And if patients are healthy, they require surgical exploration for confirmation of diagnosis. And Bosniak 4 is nearly universally malignant. The appearance is similar to type 3, but they also have enhancing mural components adjacent to but separate from the wall or septum. And the contents have got solid tumor necrosis and liquefaction, That is why this is actually quite a important diagnosis that we pick up and not. CT scan sensitivity is about 94%, but MRI is superior in correct characterization of the benign lesion, and therefore if you have an equivocal lesion before undertaking an invasive procedure, it may be good to do an MRI. The T2 weighted turbospin echo images are especially helpful to give additional characterization of the lesion that we are seeing. So the algorithm to follow is thus: if a patient's renal mass is detected incidentally on ultrasound or CT, does the patient have symptoms? Yes, then a CT scan and urological referral is urgent. If there are no symptoms and just incidental pickup, then what is the Bosniak classification? If it's 1, then nothing to be done. 2, nothing to be done unless it is 2F, which requires surveillance with CT scan at 6 to 12 month intervals. 3 is indeterminate, therefore you could do an MRI or straight away go for surgical exploration depending on the clinician's decision. And 4 is presumed malignant, and therefore you can either do an MRI or straight away proceed for excision. However, we sometimes have pitfalls in when we make a diagnosis. One of these is pseudo enhancement. The plain CT shows a 1.2 centimeter mass of low attenuation, and we have called it a simple cyst. But a contrast CT, the enhancement is slightly more, suggesting enhancement. However, the small size, the intrarenal location, and a very intense nephrogram, these are typical features of pseudo enhancement. So what do axial T2 weighted MRI shows that the mass is uniformly hyperintense, and that confirms the diagnosis of a simple renal cyst and avoids unnecessary invasive treatment. The next problem we encounter is that we may miss the lesion. They may miss the lesion. During the corticomedullary phase, this CT scan shows that the bilaterally normal kidneys and there is no mass. However, contrast CT done at the same anatomical level during the nephrographic phase shows there's a 1 centimeter lesion. During the corticomedullary phase, the enhancement is similar to the renal medulla. In the nephrographic phase, the parenchyma is homogeneous and the lesion seen. So to maximize detection and characterization of the renal masses, it's important for us to look at the pictures of the images before and after the IV contrast and images during the nephrographic phase. We must be careful to look at each frame and not just be fooled by by an initial impression. The next pitfall I'd like to talk about is that of a pseudo tumor, where you have a mass-like configuration on this CT image on the left kidney that looks like there's a mass in the lateral left kidney. But the enhancement is similar to the remaining parenchyma, suggestive of a pseudotumor, and during the corticomedullary phase, the corticomedullary differentiation actually is intact, therefore it's actually lobar dysmorphism. It is normal parenchyma and not a renal mass. Another pitfall that we may encounter is to have a patient with pyelonephritis who may present on an image to be similar to that of a mass. For a patient with a right flank pain, low-grade fever, ultrasound showed a right renal mass. So plain CT and contrast CT images are seen here, and you can see that there's a 3 centimeter enhancing homogeneous mass-like lesion on the right kidney. Suspect to have focal pyelonephritis, and antibiotics were given in this. And the follow-up MRI after 15 days with gadolinium shows that there's near complete resolution of the mass. So the mass that was seen is no longer seen here. So this actually was focal pyelonephritis. Therefore, follow-up imaging after antibiotics is essential so that we won't make a mistake of thinking that it's a mass. Another pitfall may be to think that an abscess is actually a mass. This image shows a 3 centimeter cystic mass with thick irregular wall in the lower pole of the left kidney. Significant inflammatory reaction and thickening of the perirenal fascia suggests a renal abscess. This is important for us to know because this can be treated with IV antibiotics with or without needle aspiration and drainage. Hemorrhage into cysts may also be confusing. So this are images of patients who have high attenuation material seen. This is the plane and this is the contrast CT. Looks like there is high attenuation material in the left kidneys. This is indicative of hemorrhage into pre-existing mass. And the differential diagnosis is there an underlying neoplasm? Is that what caused this image, this picture to? A follow-up MRI done 20 days later in this case shows with T2 weighted images shows that the mass has reduced, the blood has resolved, and the mass is uniformly hyperintense. And the coronal GADO enhanced fat suppressed T1 weighted images show no enhancement. So the diagnosis is a simple cyst which had bled, and we need to image this patient later. The suggested follow-up period is after 1 year. There are other pitfalls that we may encounter. Some of these are more difficult to describe, but are radiologically important for us to keep in mind are benign complex chronic hemorrhagic cysts, a multilocular cystic nephroma, hypovascular renal masses, and heavily calcified renal masses. So it's important for us to know that then we may be fooled into thinking that there's a mass when there isn't, or when there's no mass when there is. In the next couple of slides, I'd like to talk about what is my role as a nephrologist in patients who have renal cell carcinoma. It's a very important review that I think all nephrology trainees should read, which came out in 2018 issue of Kidney International, renal cell carcinoma for the nephrologists. So chronic kidney disease is often associated with renal cell carcinoma, and renal cell carcinoma causes chronic kidney disease. It's important to know that there is a interaction of the two conditions with formation of acquired cysts and other comorbidities and exposures giving increased risk for renal cell carcinoma, and renal cell carcinoma causing chronic kidney disease with nephrectomy, comorbidities, and exposures associated with kidney injury. This is another way of looking at it. After nephrectomy, with risk factors of baseline underlying chronic kidney disease, other comorbidities that patient may have like diabetes, hypertension, age, proteinuria, smoking, and the abnormal non-neoplastic tissue that they may be there. There's loss of nephron, and either you have new chronic kidney disease or you have progression of chronic kidney disease with many a time going on to end-stage kidney disease. So a nephrologist's role is important in these patients for preoperative, operative, and postoperative management. It's important for us to stage these patients correctly. The patients should be referred to us when they've got comorbidities, especially proteinuria or resistant hypertension, and when the estimated glomerular filtration rate is less than 45 mils per minute per 1.73 meters squared. We also need to look for the risk of acute kidney injury. Our main involvement is in the postoperative management, I think, is in surveillance of the patient, looking for albuminuria, optimizing the blood pressure, the blood sugar control, addressing the risk factors, and managing the comorbidities associated with chronic kidney disease trying to prolong the kidney function for as long as possible and prevent end-stage kidney disease from. So in conclusion, incidental renal masses found during imaging fund-related problems require evaluation, and a reliable diagnosis with a practical and cost-efficient method is necessary, and combining ultrasound and CT scan is the way to go. Asymptomatic patients and those who have simple renal cysts require no further evaluation. Minimally complicated renal cysts require radiological follow-up periodically, and MRI is indicated only for indeterminate renal masses, or we have a diagnostic dilemma. And others require referral. These are who have got symptoms, they require referral straight away, or those who are solid masses, high grade malignant likelihood to our surgical colleagues for evaluation. Very much for your patient listening, and I'd like to thank the organizers once again for inviting me to give this talk. Thank you very much.
Thank you, Dr. Santosh. And if there are any questions, Dr. Santosh would like to take them now as he's traveling. I don't see any questions in the chat box either. Dr. Vinant, anybody has asked a question?
No, sir, there are no questions. And Dr. Santosh.
Yeah. Thank you very much then. Thank you very much for this time.
Thank you, Dr. Santosh. We move to the next topic. And I think Dr. Sudhir Chadda will take it up. Dr. Sudhir, please.
Finished. That's my kind.
Dr. Chadda?
Dr. Santosh has very nicely summed up the diagnostic dilemma of a nephrologist. But nowadays, we are fortunate to have a very good clinical interactions with the urologists, nephrologists, and our radiologists. And all these diagnostic dilemmas are very reasonably settled within 1 or 2 consultations. And as told by Dr. Santosh, there is a very simple logarithm which has to be followed. And now I will invite Dr. Anant Kumar to take us through his oncological talk on renal cell carcinomas.
Can you
Dr. Anant Kumar, please.
Yeah. Okay. Can you see my slides?
Yes, they're very clear, sir.
Yes. Okay. So at the outset, I would like to thank this nephro-oncology meet organized by Dr. Bhalla and Vineet. And I think this is a very interesting meet, and it encourages the interaction between urologist, nephrologist, and radiologist, as Dr. Chadda said, because we need each others to give the best to our patients. And Dr. Santosh has made my job easier. So I will not be repeating some of the things which he has said and highlight other points which he has not covered. So if you see, this is the pathological classification of the tumors. And there are lots of tumors, but which I have highlighted, you can see these are the common tumors. Clear cell renal carcinoma is the most common tumor. Then urothelial carcinoma like TCC in upper tract and is also reasonably common. And then this nephrogenic blastoma, this Wilms tumor, which is quite common in children. And then angiomyolipoma is another tumor which we often encounter. So these tumor, if I put for these 4, they will constitute almost 70-80% of all the tumors. and the rest of the tumors will fall. These are so many other categories of tumor which we keep seeing occasionally. So the renal masses could be benign or malignant, could be simple, cystic, or solid. Patient characters, clinical evolution is very important, like as told also by Dr. Santosh, that whether his patient is young or old, smoker, prior history of renal pathology, how he has presented, whether he had a fever, flank pain, hematuria, or as a palpable lump, varicocele, DPT, lymphadenopathy, weight loss, or sometimes they only present incidental tumor presented with ultrasound reports, or there are some abnormal laboratories. So, but you can guess it also, like if the patient has presented with hematuria, flank mass in an elderly population, probably it could be a malignant pathology and kidney tumor. If it is if the patient has presented with fever, renal angle tenderness, dysuria, pyuria, history of stone disease, prior urological intervention, then infectious pathology becomes the more common. But the most common presentation nowadays, the patient goes for health checkup or some other reason, he has abdominal pain, and ultrasound is done, and you can see there is a small tumor or tumor is sitting. Sometimes large tumors remain undetected and there is no symptoms, and patient directly present with the metastasis. And this is the radiological classification. The previous one which we have shown you is the pathological classification, but this is the radiological classification. And here patient may present with the simple cyst, complex cyst, fat containing mass, very strongly enhancing mass, moderately enhancing mass, multifocal mass, infiltrating mass, and calcified mass. And depending on that kind of mass, the radiologist usually guess what it is. And most of the time they are right, because these have a very characteristic imaging facility. Now, the Bosniak classification, which Dr. Santosh has elaborated, so I would like to see that when Bosniak has submitted this, and 2 years back we had a very good paper published in Journal of Urology, where they have shown that what is the problem of Bosniak classification, because in this it is quite subjective, like how radiologist or you perceive the enhancement, and somewhere it is a perceived enhancement which may differ between radiologists to other radiologists. So they have modified and come out with the upgraded system. So basically you have to now, it is not the perceived one, you have to exactly see how much is the enhancement. And depending on the enhancement, you can put it into different categories. Usually the type 1 and type 2 are very straightforward, but it is the 2F which sometimes maybe you may be thinking 2F and it could be 3, and it has happened, like we have accepted the donor with the 2F, and when we excised it and sent to pathologist and came out to be malignant. And sometimes you think that it is 2F and you are following up, and next follow up you see there is a part enhancement has increased and there is some area which is showing abnormal. So and 53 and 4 are not difficult. If there is a solid component and the septas are enhancing, part of the capsule is enhancing, and there is a thick area which is enhancing, they're definitely malignant. So there is no doubt about that, and they can be. There is another thing that it is very common in male sex as well as the tumor size. If the tumor is less than 1 centimeter, then most of them are benign. There are few are malignant, like. But if it is around less than 2 centimeter, then again it could be a benign. 40% will be benign. But when it reaches to 4 centimeter, then around 20 to 30% will be benign, the rest will be malignant. And if it is more than 4 centimeter and less than 7 centimeter, then only 6% are benign. Basically, they are angiomyolipoma, but most of them are malignant. So the size of the tumor is also important. And if you are keeping the patient in follow-up and the tumor size is increasing at a faster speed, then it is a malignant tumor. Laboratory parameters, most of the tests are done, but nowadays the renal preservation is very important. And even if there is a normal contralateral kidney, patient has 2 normal kidney and there is a tumor, still we try to preserve the renal parenchyma. So apart from this, it is very important to have their EGFR, and we also do their DTPA renal scan, and also look for the comorbidity, like as Dr. Santosh said, to look for the hypertension, diabetes, ischemic heart disease, or what is their kidney function, because depending on that, we might alter our management. CT appearances of renal tumor is very classical. And that is the one tumor where the biopsy is usually not indicated. I'll come to that later on. Because if you look at this picture, it is a nicely enhancing tumor. And the most important thing is heterogeneous enhancement. Like you can see it here. This is homogeneous enhancement and this is heterogeneous enhancement. And radiologist can tell, like here the Hounsfield unit was 30 and now it has become 70 or 100. Here it is 50. So it is irregularly, heterogeneously enhancing tumor, and they are 100% nothing but the malignant tumor. So that way the CT scan picture with contrast is very diagnostic. And apart from that, we also see whether there is a thrombus sitting in the renal tumor, part of the renal vein, full renal vein, and if it has gone to the IVC, how far it has gone. Is there associated lymph node or any other feature of like part of the liver seen or any other evidence of metastasis? If you're looking for exact location of the renal thrombus into the IVC, which is very important because treatment and our preparation for the operation differ, MRI is more diagnostic. And sometimes we also use transesophageal echocardiography when it is reaching to the atrium to see whether how mobile it is and what is happening there. So that these are the investigation we often do to stage the tumor. Nowadays, I told you that renal preservation is very important because renal mass functioning kidney tissue is very important, because if the functional kidney tissue goes down, each GFR goes down, then we know that patient will slowly land into end-stage renal failure. And we also know that if there is a kidney function, GFR is less, then cardiovascular morbidity is more, and cardiovascular mortality is also more. So we have to make sure that if possible should preserve the renal parenchyma. So nowadays, even if the tumor is, initially it was up to the 4 centimeter tumor in the presence of normal contralateral kidney, but even today, if the tumor is up to 7 centimeter and there is a normal kidney and the kidney at least 30-40% green parenchyma can be preserved, we do partial nephrectomy. And with the help of the robotic system, we are doing very regularly partial nephrectomies of very complex tumor. I will show you few of them, and we save it. Like only 10 years back, we can never imagine that kidney can be saved and radical nephrectomy was the treatment. But now we can save most of the kidneys. Like you can see it here, there is a tumor here. It's a very simple partial nephrectomy. Here you can see it is all endophytic tumor. Such tumor, usually you cannot diagnose when you are doing partial nephrectomy unless you have intraoperative ultrasound. Now we have two things. We have intraoperative ultrasound, which we can throw the probe inside the abdomen and exactly see where it is and mark our line of resection. We can also use ICG, that is a firefly technology. We inject the dye and the normal parenchyma will look green and tumor will look less green and heterogeneous. So we can also mark it where this transition is happening. And if you see it here, this is completely intrarenal pelvic tumor. We have done many such tumors, and here we can enucleate the tumor from inside and save the kidney. And nowadays it is seen that if you properly enucleated it without disturbing the renal capsule, the results are very good and local recurrence rate is less than 1%. So now our emphasis is to save the renal parenchyma as much as possible so that they don't progress to the end stage renal failure. The role of MRI, sometimes we have the patient where the GFR is less, serum creatinine is more than 1.4, 1.5, and eGFR is around 50, 60. In that situation, we often do MRI, and if you give, and the problem is when the renal function has deteriorated, you cannot give contrast also in MRI. Gadolinium contrast you cannot give. So, but by doing T2 and T1 images, you can get a very good idea that how is the tumor is, and you can make the diagnosis. But if you can give contrast, then the diagnosis becomes easier. Nowadays, we see a lot of patients who come with the PET scan, any kidney tumor, they'll come PET scan. But I can tell you the PET scan has got the limited value. We do PET scan when we are thinking of metastasis, the patient, we are thinking of recurrence, or the patient has presented with advanced stage and we know that there may be a tumor elsewhere, only then we do PET scan. But if there is tumor is 6-7 centimeter, abdominal CT is normal, then we do only ask for HRCT. Do not ask for PET scan. If HRCT is clear and there is no lymph node in the abdomen, there is very, very unlikely that there will be any metastasis anywhere in the body. And there is no role of PET scan. So PET scan is only when the recurrence of disease, in follow-up disease, when we are thinking there is a metastasis. Nuclear scan, especially what like Santosh said, that pseudo tumor, which I'll be showing, we often encounter this question, whether it is a pseudo tumor or whether it is a tumor or what it is. There the DMSA scan is important because the tumor, normal kidney will have homogeneous uptake, but the tumor will be photopenic. And that way you will know that this is tumor and this is not the things. And this is the HRCT, like X-ray chest. If you do see, there is nothing there. But if you do HRCT, you know there is a metastasis. So nowadays we don't rely on CT chest, we rely on HRCT. And if you see that limitation of imaging, like you can see the two tumor here, and you may think both are same, that could be renal cell carcinoma, but there are different characteristics by which one can diagnose. Like this is oncocytoma and this is RCC, and they have different. And some of the radiologists can guess it and can tell us it could be a chromophore adenocarcinoma, or it could be oncocytoma. When to do biopsy? Should we do biopsy? Should we not to do the biopsy? Biopsy was always fraught with the danger. And it was presumed that if you do the biopsy, there will be a tumor seedling or there will be hemorrhage. But nowadays, with this two-cut biopsy needle and good imaging and our good interventional friends, it has become a very important diagnostic tool, and risk of seedling is also very less, as well as the bleeding is also very less. So when should we do the biopsy? Sometimes, like we have come with a patient which has got the metastatic deposit in the kidney. Then and there is other metastasis. We want to know whether this kidney one it has gone from the kidney or what it is. You need to do the biopsy. If you suspect the primary lymphoma of the kidney, then you should do the biopsy. Sometimes there is a small renal mass and you don't want to do the surgery. You want to keep the patient in active surveillance, or you want to do ablative surgery like cryoablation or radiofrequency. At that situation, it is also important to know what tumor you are dealing with. What is its grade, whether it has got any other poor diagnostic feature, then probably treatment might change. So all those, and if you are thinking of giving them immunotherapy or chemotherapy, that in that TKI, then you also need to have a biopsy. In the metastatic RCC, if you are not going to remove the kidney, you need to have a biopsy. And depending on that tumor pathology, you might decide about TKI plus immunotherapy or immunotherapy alone. Sometimes we get a atypical mass, especially the patient who are in the renal failure or who are on dialysis dependent or who are going for kidney transplant, and there is atypical mass and we don't know what it is, whether it is a pseudotumor, whether it is a hypertrophic renal parenchyma, and that situation you might also do a biopsy. And in this situation, chances of bleeding is less with the TrueCut needle, and seedling is also very, very rare nowadays. So this is the chart which probably Santosh has also showed, but there is little difference between these two. So like when you see the renal mass, you should see whether it is a solid or complex. If it is a simple one, then you should know what is the water density, how is the septa, septa is enhancing any calcification, depending on you can watch them or do it. If it is a complex cyst or tumor, and that you should see how is his EGFR. If EGFR is reasonably okay, you can give CT contrast and do 3-phase CT scan. Nowadays we do, and that gives very good importance. You have to do arterial phase, venous phase, and wait for contrast to be secreted. And if it is GFR is less, then probably go for MRI, or we can also give the contrast with the ultrasound. There is a ultrasound contrast, and we can also make the diagnosis. So if you see simple cyst, observe it. If it is a complex cyst, definitely the risk of malignancy and we should operate. If the fat present and it looks like black and it is very classical to identify it, then it is a likely AML. The small AML are watched, very large AML are embolized, and that if it is reasonably possible, then they are excised. And here we do only enucleation. And the solid mass, if once diagnosis is made, then we'll tell you what is to be done. Renal pseudotumor, it is a hypertrophic isolated islands of renal parenchyma, usually between the two scars. Sometimes the patient had multiple episodes of pyelonephritis, and between two scars, there is a hypertrophic tissue, and that also come out and present as a tumor. And we know it is a pseudotumor. Like renal pseudotumor is, if you see it here, here is a renal pseudotumor. And when you do DMS scan, this is the part which we are thinking of the tumor is taking up. Rest of the kidney is not taking up because this patient also has his GGFR was around 20. And that here you can see that whatever uptake has come is only come in this here. That also helps in making the diagnosis that this is the pseudotumor. Now I just give you few cases to give you idea. Like here you can see a tumor here. This is a very good tumor. Even if you have a normal contralateral kidney, or if it is a solitary kidney, we can nicely cut this part and take it out. And the loss of parenchyma is around 10%. So most of the kidney function will be preserved and partial nephrectomy will be done, which can be done by open, lap, and robotic. And the results are similar. And lap and robotic give minimal invasive. Open has got the advantage that you can do hypothermia, which is not possible in robotic and laparoscopic surgery. Sometimes we see multiple tumors, and sometimes multiple tumors are associated von Hippel-Lindau disease, which is not very common in India. But when I was working in Cambridge, in that area, it was initially diagnosed and a few century back, and there it is quite common. And we often used to do cryoablation in every week. So this is the things which is quite common. And but nowadays, even if you have a multiple tumor, you don't have to remove. We can remove, inoculate each tumor, keep preserving the kidney. We have a patient in which we have operated 3 times and removed 6-7 tumors, and still the kidney is functioning. And especially if it is a solitary kidney, we have to preserve the kidney, make sure that patient does not proceed to the end stage renal failure. Sometimes you get multiple angiomyolipoma in both the kidneys, but kidney function is okay. So in such patient, you can put the high dose of everolimus, and there is no need to operate unless someone start bleeding and causing complications. Now there is a few incidents which I'll show you. We have very interesting patients, like these are the real patients, like patient who has got the tumor here, but he also had a CKD. His serum creatinine was 2.2. He is 70 years old. He's a diabetes mellitus and hypertension. So we went ahead and did his partial nephrectomy, and his GFR has not changed because we just did enucleation and did the rhinography, and estimated GFR and serum creatinine did not change. So we preserved the renal function, and whatever medical disease he has will continue. There is another patient. If the same patient, suppose, had other comorbidity, like he has a very poor heart, diabetes, hypertension, and his kidney function is probably, suppose it is a 4 or something, then and it is a solitary kidney, or other kidney is small or non-functional or medically knocked out. So in such patient, there is no need to do operation. Just keep them watch, because renal tumors are sometimes, they don't progress very fast. It may take 2-3 years to become involving more part and more, at least 50% of the kidney, when it will become very difficult to do anything. Because if you try to do in such situation, renal function will deteriorate. He may go on hemodialysis. His quality of life will deteriorate on dialysis. And if you just keep a close watch and don't do anything, maintain, as like what Santosh says, control the blood pressure, control the diabetes, avoid any NSAID or toxic drug, he may pull up next 2-3 years. He may die of coronary artery disease. He may die of other complication, but kidney tumor may not kill him. So such patient may be kept on close watch, and we may not operate. Or if we have to operate for some reason, then we always do open operation, because then we do hypothermia, cool the kidney to 15 degrees, remove the tumor, and do very superficial repair, ligate all the vessels. So what happens, that loss of parenchyma is minimal. Sometimes we have patients who have come with a large tumor and they are bleeding, and they also have chronic liver disease. We have, last 2 years, we have 2 such patients. They have chronic liver disease. They have child's criteria C. You can't do anything. And in that situation, and they are also bleeding. So that what we did the angioembolization and control their bleeding. So I'm just going to, this is my last slide. Yeah, this is my last slide. Okay, so you can see that the tumor treatment of tumor depends on their performance status. If there is a good performance status, you can do partial nephrectomy or radical nephrectomy. If they have a poor performance status, then you can do observation. You can do cryoablation, HIFU, or radiofrequency ablation. Like, you can just treat the tumor and don't disturb the rest of the renal parenchyma. And you can, and if they are bleeding or something, you can embolize that part and preserve the renal function so that they do not go into end-stage renal failure. Thank you very much.
Dr. Anand Kumar, it has been really nice listening to you as always. You have very nicely summed up. As a urologist, we have to have few questions to answer.
Yeah.
To save the kidney, to save the patient. If possible, we should definitely try to save the kidney. We should definitely try to preserve the renal mass, renal function. And definitely, if tumor appears to be more dangerous, it is definitely priority is to save the patient. And we should not, as we have very close interaction with our nephrology colleagues, I think as a urologist, we got very, unnecessary fear of progress of the renal function. As all the patients of CKD, it is a progressive disease. And if we, even if we preserve the kidney function will deteriorate very further because of hyperfiltration, as our nephrology colleague will tell us. And I think we'll be slightly more aggressive in saving the patient. Thank you, Dr. Anand. Very nicely summed up by you.
Thank you.
Vinand, thank you, Vinand, for inviting all of us.
Thank you, Vinand.
Thank you very much, sir. Thank you, speakers. We've had a very elucidating session here this time. And I don't think we have left anything in terms of assessment of renal mass after having these two presentations. With this, I'd like to move on to the last session, which is one of the interesting sessions. And this session will be chaired by honorable chairpersons. I'd like to invite on dais Professor Manoj Singhal, who's the Director Nephrology and Kidney Transplantation at Max Super Speciality Hospital, Vaishali, Ghaziabad. And the second chairperson is Dr. Shishir Seth, who's a consultant in hemato-oncology and bone marrow transplant at Apollo Cancer Institute, Indraprasth Apollo Hospitals, New Delhi. May I request Dr. Manoj Singhal to kindly introduce our speaker for the day, whose topic is when to suspect amyloidosis and how to treat. Over to you, sir.
Good afternoon, everyone. And I thank the organizers of this ONCONEPHROLOGY update for inviting me to chair this session. Amyloidosis, as we all know, it's often baffles us. Many times we do not suspect and we get a surprise when we do the biopsy for nephrotic syndrome in these patients. And there may be many other manifestations from which the patient come up and then we get a surprise with the diagnosis of amyloidosis. So to enlighten us further, we have Dr. Rishi Dhawan, who is a clinical hematologist at All India Institute of Medical Sciences in Delhi. Without wasting time, I will invite him to go on with his presentation and then we'll have a discussion in the end.
Opportunity to present at the ONCONEPHROLOGY update regarding amyloidosis. It is very frequent that you will encounter amyloidosis patients in your practice, and it is very helpful if you know when to suspect and show you early diagnosis and treatment is the key to improving patient outcomes. So let me start by giving you a brief overview. So a recently described term is monoclonal gammopathies of determined significance. As you can see here, there is many of you would be aware of monoclonal gammopathy of undetermined significance, a term that was coined by Robert Kyle, a doyen of multiple myeloma at Mayo Clinic. And some of these are all incidentally picked up. When you notice albumin globulin reversal in the liver function test report, and you order a paraprotein screen and you come up with a paraprotein and patient has no symptoms whatsoever, this is monoclonal gammopathy of undetermined significance. 1% patients every year progress to multiple myeloma. In many of these patients, the bone marrow plasma cells increase or paraprotein increases. However, they don't develop symptoms of myeloma. These are called as smoldering multiple myeloma. And if these patients develop CRAB manifestations, where C stands for hypercalcemia, R stands for renal failure, A stands for anemia, and B stands for lytic bone disease, it is called overt or multiple myeloma. More often as compared to progression, many of these patients remain stable over a period of time, and apart from being on clinical evaluation and follow-up, they don't need to undergo any form of medical intervention. Some of these MGUS patients, Gianpaolo Merlini and Stone described, the Asperus harbor dangerous small clones. These are these dangerous small clones. They don't progress to myeloma in the however they lead to end organ damage, and the progression is caused by protein alterations. And here is we classify AL amyloidosis or light chain deposition disease, and they are classified as monoclonal gammopathies of determined significance. They lead to heart, kidney, or liver failure, neuropathy, GI involvement, soft tissue involvement. So these clinical significant monoclonal gammopathies patients harbor plasma cell clone, so it is neoplastic. It is a clonal disease, and the clone produces a monoclonal protein. It does not meet the criteria for an active malignancy, and it results in end organ damage. With this basic overview of where we put amyloidosis in a schema of plasma cell disorders, let us move on to a clinical case. So here is a 65-year-old gentleman who developed a history of hypertension and developed heart failure over the course of 6 months. In the previous 2 years, he had progressively reduced, and his blood pressure had progressively reduced, and he eventually had to discontinue his ACE inhibitors due to resolution of hypertension. Cardiology evaluation raised suspicion for amyloidosis, and a cardiac MRI was done, which showed late gadolinium enhancement. He underwent a bone scintigraphy, which showed cardiac uptake. So with diagnosis of senile or transthyretin wild type amyloidosis was presumed. So systemic amyloidosis, just a moment. Yes. So systemic amyloidosis are a protein misfolding disease. These patients harbor mutations, as a result of which there is an increased synthesis or reduced clearance of protein aggregates, and they have an intrinsic propensity to accumulate in the body in various organs and lead to tissue damage. There are the various forms of systemic amyloidosis. There is the most common of these is light chain or AL amyloidosis, which is an acquired disorder. And it, as you can see on the right side of the table, there is a cardiac and kidney involvement are predominant, and they can have liver infiltration, nervous system involvement, and soft tissue involvement as well. What is more important to grasp in this table is the middle column, where you can see that AL amyloid is the only one that presents with simultaneous heart and kidney involvement. That is one point. And the second point is that when you compare AL amyloid versus transthyretin amyloid, be it hereditary or acquired, that is the wild type, both will have heart involvement. However, if you order a bone scintigraphy scan, it is the transthyretin amyloid that will light up on the scintigraphy scan, whereas AL amyloid will not light up on the scintigraphy scan. So, you know, a technetium pyrophosphate scan, like a bone scintigraphy scan, it gives you a clue of a non-invasive tissue diagnosis of amyloid. What is important to keep in mind here is that 25% of transthyretin amyloid will harbor a paraprotein as well. So if a paraprotein is detectable in the blood, it is always important to seek a tissue biopsy diagnosis. However, if the paraprotein is not detectable in the blood and you have a suspicion for cardiac infiltration by amyloid, a bone scintigraphy scan will be helpful. So in our patient, index patient, immunofixation revealed kappa Bence-Jones proteins. Please remember, this patient was, we had suspected a cardiac amyloid on the basis of echocardiography, and a bone scintigraphy scan had suggestive of a transthyretin involvement. However, this patient also has a paraprotein. So the patient was then referred to a center for amyloid typing. Clinical evaluation revealed New York Heart Association class 3. Involved free light chains are was elevated with a difference difference in between the involved and uninvolved free light chain was 186 milligrams per liter, and a free light chain ratio was elevated as well. Bone marrow plasma cells were 12%, no chromosomal abnormalities, and no lytic lesions seen on the CT scan. Blood counts, calcium were normal, no crack features suggestive of myeloma. EGFR is as shown, and the proteinuria was significantly elevated of 2.8 grams per 24 hours. And NT-proBNP and cardiac troponin I were significantly elevated. Abdominal fat aspirate showed AL kappa. And a final diagnosis was light chain AL amyloid with cardiac stage 3B and renal stage 2 involvement. Further, I will elaborate on how staging is done. So amyloid is a very deceitful disease, and it takes time to arrive at a diagnosis. The left side of the slide shows the various clinical features and organ involvement seen in patients. On the right side is a study which was published in American Journal of Hematology a couple of years back. You can see here that if there were two groups of patients. In the one, there was a plasma cell dyscrasia diagnosis. These patients were followed up, and symptoms and signs, when they developed, there was an interval of 10 months from the development of symptom of signs to amyloid light chain diagnosis. However, in the lower group of the patients, the 38 patients, symptoms and signs preceded a plasma cell dyscrasia diagnosis. And in this group, you can see that the involvement, the diagnosis after development of symptoms and signs was 20 months, almost double. So this study I have cited here to illustrate the deceitful nature of this disease. Often when the patient comes to you with symptoms and signs, it takes a longer time to diagnose amyloid as compared to a patient who has a plasma cell dyscrasia diagnosis, and is on a regular follow-up, and the amyloid is diagnosed relatively early in this group of patients. Why is this important? It is important because on the lower right corner of the slide, you can see that once the patient develops organ infiltration, there is a very high probability of these patients dying early due to cardiac involvement or going on dialysis as a result of renal involvement. Pre-symptomatic diagnosis is possible in these patients. The increase in the free light chain levels precedes symptoms by more than 4 years. So if you have a patient in whom you can monitor, you can diagnose early before the organ involvement occurs, and can lead to meaningful improvement in outcomes of a patient. Biomarkers like N-terminal pro-BNP and cardiac gadolinium and enhanced cardiac MRI are helpful in diagnosis. So patients with a monoclonal gammopathy of undetermined significance and an abnormal free light chain ratio should be monitored to detect organ damage caused by light chains. The NT-proBNP confirmation, if it is there, should be done with cardiac MRI. These are non-invasive diagnostic methods to pick up amyloid. They should be monitored for albuminuria, and their alkaline phosphatase levels should be monitored to pick up liver infiltration early. If you are screening your patients well, you can expect one MGUS patient to pick up one MGUS patient progressing to AL amyloid for every 7 to 10 who develop multiple myeloma. What is more tricky and what is more challenging is tissue typing of amyloid. I have shown in the previous chart the various types of amyloid proteins. We are mainly sensitized towards light chain amyloid, and rightly so, because those are the ones who progress aggressively and who respond to treatment also very well. However, it is occasionally challenging to exactly type the amyloid. On the left side is a patient of cardiac AL amyloid, where the cardiac biopsy showed weak staining for lambda light chains and strong staining for TTR, which was not the case. So TTR can be false positive on biopsy, and the light chains may be falsely negative on biopsy. Why is this so? And how we can overcome this diagnostic challenge. One is the biopsy site. the diagnostic sensitivity of an abdominal fat pad is 80%. And if you combine it with a bone marrow, which is 70% if done alone, the pickup rate goes up to more than 90%. The typing of the light chain microscopy immunohistochemistry is important. You see, with the commercial antibodies which are available in our labs, they are often unreliable because amyloid protein, when it gets folded, many times the epitopes get hidden as a result of folding, and the results may be false negative. However, if we have access to custom-made antibodies, the 94% can be classified. Electron microscopy immunohistochemistry is also very good. What we hope to is to have access to mass spectroscopy with the laser capture microdissection, because it is not antibody dependent. It is the gold standard to diagnose various types of amyloid, and it is very helpful in monitoring response to treatment as well. This is mass spectroscopy, and on the lower half of the picture, you can see the various types of proteins that can be typed by this technology. Risk assessment. Initially, the Mayo Clinic and the European staging system classified patients on the basis of NT-proBNP and troponin I alone. However, in 2012, the Mayo Clinic put forth a new classification system which had difference between the involved and the uninvolved free light chains as well, in addition to proBNP and troponin I. The renal system, the renal staging system takes into account proteinuria and EGFR. What is important to note here that patients who have stage 3B cardiac involvement, they die within a year of diagnosis. So our 65-year-old gentleman, our index patient who was diagnosed with AL amyloid with cardiac stage 3B and renal stage 2 involvement, he received an attenuated treatment with cyclophosphamide, bortezomib, and dexamethasone. And I will show here that this is currently most widely accepted standard of care for treatment of these patients. So in this cartoon, you can see here on the left side is a dangerous B cell clone. And we have various treatment agents which are used for myeloma, multiple myeloma treatment as well. We have alkylating agents in form of melphalan and cyclophosphamide, bendamustine, immunomodulatory drugs like lenalidomide, pomalidomide, and proteasome inhibitors like bortezomib, carfilzomib. There is a new agent on the block which the use of which will venetoclax. It is a BCL2 inhibitor, and then there are monoclonal antibodies like daratumumab. These are usually used. The initial studies and efficacy are proven on multiple myeloma, and as more and more data accumulates, the therapeutic use gets cascaded down to amyloidosis as well. Then we have an antibiotic doxycycline, which there is data to suggest that it prevents the light chain toxicity and is an adjunctive therapy and is helpful in improving cardiac outcomes as well. So with regards to further risk stratifying this disease, these are dangerous small B cell clones. The median bone marrow plasma cell infiltrate is around 10% in most of these patients. When we do a bone marrow examination, we send a fluorescent in situ hybridization on plasma cell selection, the selected sample, to look for two translocations. The first one is translocation 1114, which is present in around 50% of the patients. Why it is important? Because these patients harboring this translocation 1114 don't respond very well to bortezomib. And however, they respond very well to melphalan, the conventional acting agent. The other cytogenetic abnormality we look for is gain of chromosome 1q21, which is present in around 20% of the patients. And this responds poorly to melphalan. So, 70% of the patients, they respond either to bortezomib or to melphalan. And other translocations on cytogenetic abnormalities are rare. A myeloid plasma cell relies on ubiquitin proteasome pathway to cope up with the accumulative light chain toxicity and are exquisitely sensitive to proteasome inhibitors. So the choice of treatment, we have to balance the expected efficacy in terms of response rate and duration, characteristics of the clone, as I have elaborated previously, or chromosomal abnormalities, and patient access to drugs. Along with balancing it with severity of organ involvement, which is judged by biomarkers, namely NT-proBNP and troponin I and 24-hour urine protein excretion. So specific contraindications which patient may have in terms of neuropathy or renal failure or lung fibrosis. So neuropathy and lung fibrosis patients, they don't do, we tend to avoid bortezomib in these patients, and frailty. Which is mainly determined by age and comorbidities. Along with these balancing factors, we need to take patients' preference into account as well. Occasionally, we get patients who are very frail initially. How in these patients, it is you can introduce the treatment gradually. And once the patient's performance status improves, the patient from horizontal prostration goes to, can stand up and resume his activities of daily living, then we can switch to a more aggressive treatment. Autologous stem cell transplant, initially when we took into account the initial data, was not very promising with autologous stem cell transplant results in amyloidosis. However, as more and more data accumulated and we were able to risk stratify these patients, we have a reasonably good amount of success in transplanting these patients, and the overall response rate is now 84% with autologous stem cell transplant. Who are eligible upfront for autologous stem cell transplant are only 20% of the patients who fulfill these criteria in terms of they are relatively younger, they have a good performance status, they are not frail, their biomarkers below a certain threshold, their organs in like heart and kidneys are working fine. They have a good blood pressure, the liver is not involved with disease, and they have a good lung function. So these are the patients whom we expect to tolerate the intensive high-dose melphalan, which we give for autologous stem cell transplant, to tolerate it better, and the benefits outweigh the risks. And these are the patients in whom we consider upfront autologous transplant. And patients who achieve, who respond very well to transplant, who achieve a complete response, they have a better survival, as shown on the lower left corner of the Kaplan-Meier curve. Then in patients who have a bone marrow plasma cell infiltration of more than 10% at the time of diagnosis, they do well with bortezomib-based induction. And there is data to suggest that induction therapy independently increases progression-free survival as well. Many of these patients, when we treat with bortezomib-based induction, their disease responds unusually well. And in these patients, we might even consider foregoing consolidative autograft as well. So we call this as a sequential response-driven approach. And in patients who receive a transplant and who attain less than a very good partial response, we consolidate them with bortezomib after transplant as well, and there is a 60% response rate. And so that improves patients' outcome as well. So there is a group of patients in 20% of the patients in whom we consider giving an upfront transplant without any treatment if their organs are fine. Then there are patients and with transplant, the patients who respond very well after transplant assessment, they do very well. Then in another group of patients, the remaining 80% of the patients, we offer an induction therapy with bortezomib. before taking them up for transplant. A subset of them do very well with bortezomib, and we may forego transplant as in those patients. And in the patients in whom the disease doesn't respond very well after transplant, we offer again a short course of chemotherapy consolidation with bortezomib. Now, what happens to the patients who are eligible for autologous stem cell transplant? So, as I have elaborated previously, cyclophosphamide, bortezomib, and dexamethasone is now the commonest upfront therapy for all of the patients with amyloidosis. Now, in a recently published randomized clinical trial, they compared bortezomib in combination with melphalan and dexamethasone to melphalan and dexamethasone alone. Why this treatment was considered was, as I showed previously, the cytogenetic abnormalities. So there is a group of patients who don't respond well to bortezomib, and there is a group of patients cytogenetically who don't respond to melphalan. So why not combine both of them together to cover for both the cytogenetic abnormalities, namely translocation 1114 and gain of 1q21. To both the group of patients will be covered with this treatment. And we can see here that patients who received bortezomib in combination with melphalan and dexamethasone had an 81% overall response rates. And for the remaining cardiac and renal categories as well, the response rates was improved, albeit not significantly. The new agent on the block is daratumumab. This is available in India. It is marketed. The main problem is the cost. And there's a recent study, Andromeda study, which was published. And we can see here that subcutaneous daratumumab is the subcutaneous is not available in India at the moment. However, we have IV daratumumab. Both the formulations are different and are not interchangeable. So daratumumab subcutaneously in combination with cyclophosphamide, bortezomib, and dexamethasone have significantly improved outcomes with regards to organ deterioration and progression of the disease as compared to the patients who are getting only cyclophosphamide, bortezomib, and dexamethasone. So treatment of intermediate and high-risk patients, the current treatment of choice is cyclophosphamide, bortezomib, and dexamethasone in combination with daratumumab if accessible and if the patient can afford it. The response rates with this combination are more than 90% with upfront therapy. If the daratumumab is not accessible, consider cyclophosphamide, bortezomib, and dexamethasone in patients with potentially reversible contraindications to autologous stem cell transplant, and in those with eGFR, which is less than 30 ml per minute per meter square body surface area. This combination is less effective, as I have elaborated previously, in patients who harbor the translocation 1114. For patients who are not transplant eligible, let's offer a treatment of bortezomib, melphalan, and dexamethasone, as it potentially overcomes the effects of both translocation 1114 and 1q21. However, it is important to note here that we never use this combination in patients in whom we are considering transplant candidates, because melphalan, it interferes with later stem cell collection. Hence, it is always used in patients who are transplant ineligible. The high-risk patients are the ones who have cardiac stage 3B, New York Heart Association classification 3 or 4 level of breathlessness, and performance status of 4. These are the group of patients who need intensive monitoring during therapy, as they are at risk of suffering a sudden cardiac death. And these are the patients who have a very poor performance status. They are bedridden. They lead a typically bed and chair existence. But it is important to start with reduced doses and escalate if well tolerated. What is important to note here is that, in these high-risk patients, occasionally we will get an early and deep hematological response. And these are at 30 days, if they attain a complete response or a very good partial response, then these patients do very well. So it is important not to ignore treating these patients. We need to treat these patients as well. And a rapid and a profound reduction of amyloid-free light chain should be the term goal of treatment. Patients who fail to reach this goal, at 30-day evaluation, should be shifted early to rescue therapy to preserve the chances of a better outcome. How do we assess response in amyloidosis? So the response is assessed in terms of hematological and organ-specific response. So the upper table shows hematologic response, where complete response is all the no paraprotein is detectable. A very good partial response is if we achieve a difference in free light chain between the involved and the uninvolved free light chain is less than 40 milligrams per liter. And a partial response is when the difference falls by more than 50%. And the cardiac response is if there is a 30% or more than 300 nanograms per liter decrease in cardiac biomarker. And the renal response is judged by if there is a 30% decrease or a drop of 0.5 grams per 24-hour decrease in proteinuria. So, and recent advances in recent advances in flow cytometry have enabled us to detect plasma cell clones below what is visible by the conventional microscopy. And we call it as measurable residual disease assessment. So it is measurable, but it is not morphologically visible under conventional microscopy. So we use flow cytometry to detect these plasma cell clones. And approximately 50% of patients in complete response are reported to be negative by next generation flow. The absence of clonal bone marrow plasma cells by standard sensitivity flow cytometry is associated with improved progression-free survival. So if the disease is not detectable by flow cytometry, if the plasma cell clone is not detectable by flow cytometry, then there is a very good chance that these patients will enjoy a longer progression-free survival, and the organs will remain free of disease for some time as well. So in our patient, he attained a very good partial response along with cardiac and renal response after 4 cyclophosphamide, bortezomib, and dexamethasone cycles, and treatment was discontinued. And he was and a follow-up testing was scheduled every 3 months. And we can see here that compared to baseline after upfront treatment, his difference of free light chain had decreased. However, it was still detectable by immune fixation. That is why this is VGPR. And his cardiac biomarkers and renal biomarkers had decreased by more than 30%. However, at 15 months, there was a relapse. And we can see here that the difference in free light chain was almost 50% of what it was, had increased to up to half of what it was at the time of diagnosis. So when should treatment start at relapse? There is no.
I'm sorry, sir. We are exceeding our time. So if you can just sum up in next few slides.
Yes. So I have only 3 slides remaining now. So there is a disagreement on timing of treatment, and validated organ progression criteria are do not exist as now. However, we should not wait for organ progression, and hematological progression criteria are sufficient enough to start a salvage treatment in these patients. And amyloid M protein, even if it reappears, it can be asymptomatic, and the organ progression will be later. So it is better to intervene early rather than later once organ progression starts happening. So the salvage treatments are mainly lenalidomide and daratumumab. And these lenalidomide we don't use upfront. However, we use it at relapse, and around 30% of the patients attain a good response with this treatment. Daratumumab is far more promising, and there is a more than 90% hematological response even in salvage, with around 50% cardiac and renal responses. So our patient was relapsed after 15 months. He was treated with daratumumab, bortezomib, and dexamethasone. And after 1 week of treatment, his very good partial response was reestablished, and we can see here. And so coming down to conclusions, so management of light chain amyloidosis, we need to remember that biomarkers allow early diagnosis, risk-adapted treatment design, and reliable assessment of response with validated criteria. Now we have new standards of care for these patients in terms of transplant, bortezomib, melphalan, dexamethasone combination, and very soon daratumumab. However, we need to improve early diagnosis. That is because as I mentioned earlier, early diagnosis is tricky, and define a standard of care for high-risk patients. We need to validate a definition for hematological progression to identify time points where intervention in patients who are progressing will lead to meaningful outcomes. And we need to validate new sensitive technologies like mass spectroscopy and measurable residual disease to assess response. And we need to keep up the research to identify alternative treatment targets. Thank you, and I am happy to take questions.
Thank you, Dr. Rishi, for giving very summarized talk about amyloidosis. That is a complex topic and quite difficult to diagnose sometimes. Means it is diagnosed mainly during biopsy by a nephrologist, but as you told that there are some blood investigation, they also can give a means a clue. And so means definitely means primary amyloidosis and multiple myeloma, though treatment is more or less similar, but the prognosis is a little different because the residual effect of myeloma, they are very little because means these abnormal protein, they are not deposited in the tissue, but means in amyloidosis, abnormal protein that is deposited in the tissue, and so far we don't have any specific therapy to remove this abnormal protein. So that's why we are relying to develop a tumor means at earliest possible. And means many of such patients means who are doing very good means if they are requiring renal replacement therapy, so they can be considered for even renal transplant later.
Dr. Dhawan, there is a question in the chat box which there are side effects of daratumumab or whatever antibodies.
So daratumumab is a monoclonal antibody which is directed against CD38, which is a marker getting expressed on plasma cells. And the main challenge with this antibody is one is it has to be given under in the hospital at least for the first 2 to 3 doses, because even the tracheobronchial epithelium expresses CD38. So these patients are at risk of developing bronchospasm. And the second is as it depletes the plasma cells, so it occasionally we might get hypogammaglobulinemia. And these patients are at risk of infections here because it impairs the humoral immunity. There was a there was a recent study that showed that these patients are at risk of developing listeria infection as well. However, in most of the patients, if given with an adequate amount of pre-medication like montelukast and steroids, the patients tolerate infusions very well. And later on, they can, instead of 4 hours of initial infusion, the infusions can be given in 90 minutes as well. So it is largely well tolerated in most of the patients.
Good, thank you. Thanks a lot. So I think since we are running late, we can close this session, and I hand over the podium to Dr. Vinant and Dr. Bhalla, the organizers of this committee, of this meeting.
Thank you, Dr. Manoj. So with this session, we come to the end of this update. Now, coming to sort of validatory function, at the outset, I would like to thank all the speakers and chairpersons and the colleagues who have attended this 2 days of update. It was a big effort to involve the nephrologists, urologists, oncologists, hematologists, and even in the international speakers. We had wonderful speakers from New York, US, and they contributed a lot in this by delivering their thoughts. So I'm really grateful to all of you for making this a success. I'm sure there must be some shortcomings. Time management was a problem, and we exceeded yesterday also and today also. But the topics were such that it was not easy to cover in the stipulated time. So we'll take this fact when we plan the next update. And we could not accommodate many speakers. A lot of people wanted to give talk on various topics, but because of the shortage of time, we could not accommodate many speakers. I thank all of you for making it a success and sparing your valuable time to attend this function. If I can have comments from Dr. Rana and Dr. Vinant Bhargav, if they are here. Dr. Rana, sir.
Well, I must congratulate you all, and especially the participants and the speakers. It really enriched the knowledge of regarding oncology related to nephrology and urology. I missed few lectures because of some meetings, but I listened to most of you. And it was really very, very, appreciable to listen to all the speakers. They have prepared such nicely and to know all about what is happening in the onco field actually. And I think we discussed common topics and very nicely. Congratulate you all, and thanks all the delegates and especially the faculty members to participate and spare time. Wish you good luck for the next update after 6 months.
Thank you, sir. Thanks for your blessings. It is all with your guidance and the leadership qualities that we continue to excel. And we are
I am very good that you're excelling in all your endeavors, and wish you best of luck in all this.
Thank you, sir. Dr. Vinant, last comment by Dr. Vinant.
Yes, sir. So thank you, respected chairperson, speakers, faculty, as well as my senior mentors, my senior colleagues, Dr. Manish Malik, Dr. Anurag Gupta, as well as my fellow colleague, Dr. Weber, who have been all instrumental in planning this program. The conception of this program has been with Dr. A.K. Bhalla, who came up with the idea about 4 months back when he said that onconephrology is an emerging field and we should do a topic on that. So the scientific content was all designed by the entire department. I would also like to extend thanks to the industry for having supported the cause. There are a few points that I would like to conclude with. First is that all of these lectures have been recorded on YouTube as well as on the platform and are available for your kind viewing over the next 7 days. You can also select YouTube as a live streaming, and you can save the lectures if you wish to. I have taken permissions from few of the speakers, and they are gladly happy that you can use their lectures. Second is the attendance certificate can be downloaded from the website, from the platform. There is a tab on the facade, which says, on the lobby facade, which says certificate download here. If you do not find that tab, you can go to the stalls counter where you can download the tab. And third is, as Dr. Bhalla has said, that we are open to all comments from your side for improvement for the next sessions that we're going to have. And you are requested to kindly leave your suggestions on the email, on the platform, so that you help us improve further. Thank you very much for your presence here. We had over 750 delegates on day 1, and today we had over 650 delegates participating in these sessions. Thank you, sir. Thank you, Dr. Bhalla, Dr. Rana, and thank you, Dr. Ashwini Gupta.
Thank you.
We should conclude here. Thank you very much.